Good afternoon. Hi, everybody. Thanks so much for being here. For those who don't know me, I'm Kim Milstein. I've got the great pleasure to be the CEO here at Ventura County Medical Center and Santa Paula Hospital. So welcome to our campus. And for those who haven't been here in a month, welcome to our new hospital immediately adjacent. It's been a fun month for our team here. I really appreciate you taking the time to join us today. I think this is the start of a series of important conversations that we have, as a healthcare agency, have been engaging in a lot of different places, individually and small groups. But to have the opportunity to have this become a much broader conversation is really exciting. And you know, at the end of the day, this comes down to having to care for our patients. In a lot of ways, we care for our patients very reactively and very episodically. But is that in the best interest of the health of our community and in the best interest of our patients? And I think we would all say no. And so how do we look at the broader impact of healthcare on patients and how we participate in that? It becomes less about that transactional care and more about the entire gestalt of the health community and our role in impacting that. So I really look forward to the discussion today. In your packet, you have an agenda, so you can see a very rich slate of speakers bringing different perspectives on this issue and how they impact us as healthcare providers. First and foremost, I'd like to introduce and just really thank Jonathan Gill, the director of the Ventura County Healthcare Agency, who really brings a passion for whole person care and the integration of medicine, not just at that transactional level, but really deep into the heart of the healthcare community as a passion for him. Jonathan's going to spend a little time introducing the speakers and the outcome for today. And again, I just would welcome you to the campus and look forward to learning along with you. Jonathan.
Thank you. I want to thank everybody for being here this afternoon. I know there's a lot of work, much of it being generated by me, words used, so I apologize for that. But this afternoon, I think, is very important. For those of you who've worked with me very closely over the last year and a half that I've been here, you know the things that I'm passionate about. One of which is the community that we live in, the community that we serve. And some of you know I do have a clinical background. I did train way back when as a physical therapist. It's sad that I don't practice anymore. I should, you know, but there are bigger things that need to be done, and I'm glad to be part of that. Having said that, this afternoon, I hope that you are here fully engaged with the folks that will be sharing their thoughts with us. Why? Because without that engagement, the medicine, the way it needs to be delivered, very holistically. Those of you who've had the opportunity of looking these wonderful speakers up, you would notice that that's what's very important about them. They've looked at the patient not just because the patient is in front of them, but looked at the patient from multiple perspectives. Kim, thank you very much. Where did Kim come? She was in the back. Thank you for letting us use your beautiful facility. We thank that. Thank you. I do want to ask a question. The number may be different depending on which year the report comes out. I think I just read over the weekend and preparing for some stuff. Now it's the sixth cause, as far as the deaths are concerned in the U.S. Do you know what is this? Of course, we know that heart disease still remains #1 after years of being there, but what is the sixth cause of death in the U.S.? I hear whispers. I want somebody to hear that. Pardon? No, it's healthcare, actually. And many of you will recall the studies done in the early 2000s when Don Berwick spoke about it. I think it was 2004 or 3 when he first spoke about it. The iatrogenic deaths in the U.S. We've not changed a lot, even though medicine has become a little bit safer. We have not changed a lot. Why do I mention that? That's what is happening when the patient is in front of us. But today's discussion is going to be focused around, as healthcare providers, what are we looking at? What are we looking at when it comes to the needs of our patients? And many of you have really embraced this concept of integrated care that we need to provide in Ventura County. I personally appreciate being in Ventura County because it's just the right size. And we have all the various divisions of healthcare reporting up to the healthcare agency where we can control something. Folks like Dr. Huffman and Dr. Manchanda come from large systems where moving things is very difficult. So today, as we listen to the speakers, I want you to please pay a lot of attention of what you will do differently tomorrow in the way you think about delivering care. If you're a physician, if you're a nurse, if you're another healthcare professional, please think how we're going to think about care differently. Very impressed with the work that public health has done with the community health assessment that they've done. But I was having a conversation with Rigo earlier last week, that if our community needs assessment, when done again, looks exactly the same as it has for the last many years, then we as healthcare leaders, we as healthcare deliverers have totally failed the community. Those numbers need to move. Those numbers need to move. And those numbers will not move because Ventura County Healthcare Agency or Ventura County Medical Center or behavioral health or public health is doing something. This is a much bigger challenge for the community at large. That's why today amongst you are some community CBOs, community-based organizations. We're very happy that you're here. Some may be walking in a little bit later. Why? Because what we're going to talk about this afternoon is a huge challenge. When we think of Port Hueneme and look at the obesity rate among children there, when we look at Oxnard as a whole and look at the diabetes rates there, when we look at other smaller communities in the Heritage Valley and look at the disease trends, we have to do something. We have to change those. I think of those numbers from Fort Wayne, and I think that this is the next generation of kids that are going to be the leaders that have to be taking care of us. And if majority of those, 40–50% of them, in their third or fourth decade, convert to type 2 diabetes, we have a huge problem on our hands. So without any more time, I would like to introduce our Public Health Director, Rigo Vargas. Rigo has developed and managed community-based public health programs for the last 20+ years. He has been with Ventura County Department of Public Health for the last 16 years, serving in a variety of capacities. Currently, as the Ventura County Public Health Director, Rigo is also a part-time instructor at Cal State Channel Islands, where he teaches an upper division course on health issues in the Latino community. He holds a bachelor's degree and a master's degree in public health. Under his direction, this is very important, Ventura County Public Health recently achieved a 5-year national accreditation through the Public Health Accreditation Board. Ventura County Public Health is the first public health department in the state to earn this important distinction. The national accreditation program, jointly supported by the Centers for Disease Control and Prevention and the Robert Wood Johnson Foundation, sets standards against which the nation's more than 3,000 governmental public health departments can continuously improve the quality of their services and performance. To receive accreditation, the Public Health Department underwent a voluntary but very rigorous, multifaceted, peer-reviewed assessment process to ensure it meets or exceeds a set of quality standards and measures. Rigo currently oversees Ventura County Public Health's diverse programs and services delivered by more than 325 very dedicated employees, and I've worked with that team. I've met many of those. They are truly devoted to the mission of this agency. Rigo, thank you.
This one was working in the morning. Okay.
Excuse us while we get ready with the PowerPoint to advance some of the slides. Thank you, Johnson, for that introduction. Just a quick note, I appreciate that introduction, and just an update that I no longer teach at Cal State Channel Islands. That was a couple of years ago, but I really enjoyed teaching the young generation about Latino health issues and the status of our community. I'm gonna try to move around, but not be too much in front of the audience here.
Can I take care of this? Okay, we'll just move forward.
Oh, go ahead. No, go ahead.
In terms of impacting health through social determinants, the educational objectives that we have are as follows. Review how social determinants of health impact specific populations' health outcomes. And we really want to focus on the priority health issues in our community, which is why Mr. Vargas is going to give us that background with regards to Ventura County Public Health and the report that was just published in 2017. We want to learn more about upstreamists and how that relates to healthcare, and also discuss how upstream quality improvement can improve social determinants and really work to provide better outcomes for patients, our community, and our clients, because indeed we have a diverse group of individuals learning together today. The planning committee and the presenters, there is no conflict of interest, and everything has been peer reviewed to ensure you're getting the highest quality of education today. The Ventura County Healthcare Agency CME program is accredited with commendation, and therefore we are designating this live activity for 2 hours of contact. If you would like to receive any type of continuing education this afternoon, please complete your evaluation. Otherwise, if you complete your evaluation, it helps us plan for future forums such as this. Which takes us back to get ready for our first presentation, Impacting Health Through Social Determinants. What are the educational goals for the forum today? We want to promote team-based education and address public health priorities. We're doing that as a team here, diverse group within the agency, and indeed we are diverse. Let's learn together to enhance our skills and promote educational and population health leadership. Ultimately, our goal is to achieve positive outcomes for, again, our community, our patients, and our clients. And so we bring to you Mr. Vargas.
Thank you. Thank you again for setting the stage for my presentation and for our esteemed colleagues that will be presenting after me. I really value the opportunity and thank Johnson and also the planning committee for organizing this forum and for the opportunity to highlight the important information that we believe is in our community health assessment report. And it's only looking at when we really increase efforts to looking at the social determinants of health that we believe that the road will widen in order to really achieve a healthier Ventura County. As I pondered in terms of the task before us today, in terms of further addressing social determinants of health, I wondered really what the takeaways or the questions, the key questions I think we should all be thinking about. I think the majority of us here in the room are healthcare professionals. And within the healthcare agency, I know we have some community partner organizations as well. But I would like to offer that as key questions or takeaways from my presentation, and I think also from our esteemed colleagues, is basically two questions. One is how can the information that we're going to be gathering today or discussing, how could that improve our efficiencies in terms of how we're doing our project planning and how we're delivering service? So please ask yourself that as we continue with my presentation together. So the other question is, really, how can this information lend itself to increased opportunity for us as different departments within the agency to further collaborate and integrate our services? And also, how can we increase our community partnerships with community-based organizations? And thirdly and finally is, how does this information, is it going to help us to really fully engage our clients, our community, and really attain health-driven Ventura County? So please consider those questions as we go through my presentation and the ones after me. In terms of a quick outline, this is what I hope to cover today. First, a little bit of background in terms of social determinants of health and health equity. Share with you some highlights in our report that are demographic and socioeconomic status indicators. Talk a little bit about the social needs index that really drives home that in many places, but including in Ventura County, place does really matter when it comes to health outcomes. And finally, I'll touch on a few priority areas just to give you a glimpse of the content of our community health assessment. So that's what I hope to accomplish today. I'll begin with this question: what impacts health the most? Oftentimes, we believe in the healthcare system, healthcare setting, that it is clinical intervention, education, counseling that really impacts health the most. And certainly, when someone is, any of us, when we're sick, really the top of the pyramid is really critical, and that's going to impact us the most. But when it comes to population health, when it comes to overall community health, it's really the base of the pyramid that really impacts our health the most. And that's when we get to the discussion of social determinants of health. In fact, it is these socioeconomic factors that are the main areas where we can improve health. And when we're talking about social determinants of health, we're talking about education, housing, transportation, really large social, even political, economic sources and environment that is conducive or not to health. Certainly, again, the personal responsibility and individual health care is very important, and so is the middle areas of this pyramid. It's also very important and they impact health. In fact, in public health, it's widely recognized that immunizations, smoking cessation interventions, smoke-free laws, and other types of laws such as DUI prevention and seatbelt laws have had the largest impact on health. So it's very important to address all of these. But when it really comes to making the big changes in our community, it's the bottom of the pyramid that is most important. And that is, in fact, the topic of today's session. Now, you might wonder why I'm starting off today's presentation in a room full of healthcare providers. Definition of health. It actually is because if we refer back to almost a 70-year-old definition of health by the World Health Organization, that organization, back again 70 years ago almost, as highlighted there, put an emphasis on not only mental but social well-being in addition to the physical aspects of health. But oftentimes we only talk about health as in sick care, when we're treating the individual when they're sick. And so we usually, I think the traditional sense of health, we talk about the absence of disease, but it's really a complete state of physical, mental, and social well-being. And I like this definition again because it draws attention to the social aspects. Since then, many have offered additional aspects such as spiritual and even financial well-being as really what drives home a healthy community and a healthy individual. A little bit in terms of the social determinants of health. Again, I think all of our speakers are going to touch on this. I'd just like to offer some thoughts and some perspective background on the actual topic that we're addressing today. Simply said, social determinants of health are the conditions in the places where people live, so our housing, our physical environment, where we learn, our schools, our educational system, where we work, is our health coverage, are we part-time, are we full-time, what are our wages, do we make a living wage, are we even employed, and where we play, the conditions of our children, are there streets, safe streets, sidewalks, are there parks? It is these conditions that really affect health outcomes the most. And so again, this is really a basic definition of social determinants of health. It's the conditions in the places where we live, work, and play. And some examples then of these conditions are our, as I mentioned, education, housing, our physical environment, our social status, and our poverty or opposite of that, our income, really is what drives health. Oftentimes when we talk about social determinants of health, it's in the context of health equity. And before I offer you a definition of health equity, I'd like to contrast it with health inequities. So this definition is that health inequities are preventable, key, and therefore that's why it's bolded. It's preventable or it's avoidable differences in the burden of disease or opportunities to achieve optimal health, and that these are experienced usually by socioeconomically challenged and vulnerable populations. So this definition is in contrast health inequities to health disparities. Oftentimes folks interchangeably use health disparities and health inequities, but I like to think of health disparities as simply health differences. There's always going to be differences in health outcomes. Sometimes if you're young, you're going to disproportionately suffer some diseases versus the old, male versus female, and some of those are expected. They're not necessarily preventable nor avoidable. But when a disease outcome and a burden is something that could be prevented or avoidable or it's unjust, then it's a health inequity. In terms of actual health equity, it's often been said that equity is achieved when everyone is given the opportunity or the resources to reach their full health potential, where they can thrive, where they can live long, healthy lives. So that is health equity. I think that's one of the outcomes that we, as a healthcare providers in our system, but also those of us addressing social determinants of health, we want to get at health equity. Before I proceed, I'd like to just recap a little bit in terms of our department strategic plan. A couple of years ago, we came up with this vision statement and also mission statement. Our mission statement draws attention to the environment and also about well-being. But in particular, our vision statement, we did some interactions with our frontline staff, and they really challenged our leadership at the department to adopt this version of the vision statement, which is we want to be the healthiest county in the nation by 2030. And although lofty and perhaps grandeur of this vision, it's really consistent with state and federal leading public health organizations that have also challenged our entire healthcare system, our nation, to be the healthiest in the country, healthiest state, and healthiest county. So I'm pleased to share that vision that's in our strategic plan. It's also in your copies of the community health assessment, and that I also present it because it really is going to take a whole community of all of us here as agency, healthcare agency, but partners to achieve this vision. In your packets, you have a summary of our community health assessment. This is what it looks like. At the end of my presentation, there's a link on the website, but basically this report is mostly available via electronic, and so it's on our webpage, and it's also on our Health Matters in DC.org data dashboard, and that address again will be at the end. And we hope that you utilize this as a tool in again helping you plan and deliver services to the community. Also, in your handout, as part of the summary of the community health assessment, is this handout, and it has a little bit more information. This is not our original. We didn't in public health. We did not come up with this model, but we adapted it to Ventura County. Many have used this model of the onion to demonstrate how important it is to address various factors, not just the individual or even the family, in addressing a total community, to achieving total community health. It really is issues that are more in the social and the physical environment. So having adequate and safe housing, having cultural norms that are conducive to healthy living. It's economic opportunity and educational attainment and supports. And it's also safety in the neighborhoods and in our families. And it's also having access to food, healthy food and positive media messages. All of that is really going to drive population health outcomes a little bit more than individual factors. And so what does a healthy community look like in Ventura County? We believe it's one that is going to achieve health equity, where there's going to be increased attention of health and health policies, and we thank our board of supervisors for adopting a health and health policies framework where cross-sector partners in the community, whether it's law enforcement, planning, are going to look at how their policy, the practice, or the program impacts health and who is it impacting. Also, part of a healthy community is doing periodic health assessment, and as Jonathan said, it's not just doing the assessment, but tracking progress. So our community health assessment mainly summarizes the most current relevant secondary data that is available that we have access to. But before I share that data, I'd like to also let you know that we did about 1,000 surveys and asked residents themselves to let us know, answer a couple of questions. I just offer you one. So these are the responses, both out of the almost 1,000 respondents, about 2/3 responded to this question in English and about 1/3 in Spanish. You see the difference here. I think it's interesting to note that everyone of almost 1,000 respondents of Ventura County in our community health assessment chose health access and health coverage as their number one area where that'll make a health community. And that's important. That can be a social determinant of health. But I think it's telling that factors 2 to 5 are really social determinant items, factors. So I think our residents, our community, is really in tune already to the social determinants of health and how they impact health. So for example, in the English respondents talked about low crime and safe neighborhoods as contributing to a healthy community, a clean environment, so social and environmental justice, schools, and yes, behaviors and lifestyles are also important. Interesting to note that the Spanish respondents, they also added affordable housing as among the top 5 contributors to a healthy community. So I think it's telling again that our residents are already in tune to the social determinants of health as per this, the responses here. Real quick, in terms of the, for those of you that are from outside or guests from outside of Ventura County, a quick recap of the demographics in our county. This is the latest information that we have through the California Department of Finance. Basically, Latinos and whites are the largest ethnic minority group, with Latinos only slightly below in numbers to whites, and the rest of the ethnic racial groups are around 10%. So that's current. Now, in 2060, the same California Department of Finance estimates that by 2060, Latinos will become the largest ethnic group at 55%, and Anglos will reduce to about 31%. So if we really want to address the health of the entire community, we need to address all racial and ethnic groups. Also, it's interesting to note that by this year, we're expected to hit the 1 million mark in terms of residents. We're at about 860 residents right now. So one of the topic areas in our community health assessment is life expectancy. Life expectancy is one indicator of the health of a community. Now this slide presents some interesting, I believe, and good news overall. So our life expectancy in Ventura County is 82 years of age. On average, we're all expected to live 82 years of age. That is higher than the U.S. life expectancy. Females, they know how to live healthier, they have a better and higher life expectancy. And so perhaps those differences are more due to a health disparity. It's a health difference, male versus female life expectancy. But look at the top bar and the lower bar, the ones by zip code. There's a 12-year discrepancy or gap in life expectancy in 2 zip codes in our own county. Another way to display it is this. Zip code 93022, which is the Oakview, the unincorporated area of the Ojai Valley, has a 76-year life expectancy. That child is expected to live 76 years old. Same age child living in the Westlake Thousand Oaks area is expected to live 12 years more than that child. So one has to ask now, is that a health disparity? Is that an expected, naturally occurring, an acceptable difference? Or perhaps is it a health disparity, a health inequity that's causing that difference? And so we'll examine that a little bit more. So the important, this is a little busy slide, but I just put this one in there to draw attention and to solicit your interest in looking up your zip code and seeing what your life expectancy is, but also to remind myself to let you know that whenever possible, our community health assessment breaks down the data by zip code, by city, by race, by gender, wherever we can slice and dice the data at the lowest denominator, we try to do that. One more, I think this is my last slide with regards to life expectancy. I mentioned, I think at the beginning, or I had the slide in there about the SocioNeeds index. This is a nationwide measure that takes into account socioeconomic indicators and gives them a score. The higher the score, the more socioeconomic need. And then it compares that score to a health outcome. In this case, it shows life expectancy. And you begin to see a pattern here. In the darker areas, those are the areas that are have higher socioeconomic need. In other words, there's more poverty there, there's lower educational attainment, and the life expectancy you see is actually quite lower than in the more affluent areas of our county, much higher life expectancy. So it does appear that in our county, place, in fact, matters. I'm going to go through these next 3 slides quite quickly. I just still wanted to include them here just to interest you in looking at our report, where we've done a years of life loss analysis in a new methodology consistent with the World Health Organization. And so when we look at leading causes of death, it's always interesting or important to look at preventable causes of death, and to see how the young and middle age are dying, not as a whole, but particularly the young population. Causes of death, here they are for overall causes of death on the left, and then premature causes of death are on the right. It's actually cancer has overtaken coronary heart disease in our county, and I think in the state, but not in the nation, as the #1 killer. And that's both for leading causes of death and also premature death. Heart disease is second, but if you look at now preventable and premature death, we look to see a different picture of what's actually leading to premature death in our own county. You can see now that it's accidents. It's accidents. Accidents, drug-induced deaths, suicide make the top 10. Actually, suicide was #9, but it moves up to 6. Drug-induced deaths, accidents now make up the top 10 when it comes to premature death. That's why it's really important to look at premature death and years of life lost. One last note in terms of years of life lost. This slide examines how many years of potential life was lost due to this type of death. Homicide is the #1 cause of premature death. On average, if you die due to a homicide, you're losing 57 years of life. So there's great opportunity for intervention there. Also, drug-induced deaths, there are almost 47 years of life lost due to that. And there you see for the rest, including fractures. So there's a lot of great opportunity to examine what's really causing these premature deaths. Now, the main time that I'll spend now, the minutes of my time, is really calling out some factors, some indicators in our community health assessment in each of these 5 areas. These are the 5 areas that we chose in our community health assessment as areas for increased focus in order to have a healthier Ventura County. One is creating healthier communities. So we talked about how important the environment is. So I think it's critical then that we talk about what is going on in our community. I've chosen just 2 indicators around education and poverty, just to give you a glimpse of some of the baseline information that we have in there, so that we can track it in future reports. So first, the next couple of slides are on educational attainment. And we start to see a pattern around disparities and more actually appropriately, perhaps health inequities when we talk about education and poverty. First, in terms of education, this is educational attainment for residents 25 years and older by city. And you see that if you have a high school graduation rates are much higher in certain communities. You see that close to 90% here for Camarillo, Moore Park, Simi Valley, Thousand Oaks, close to 90% graduation rates for those 25 years of age and older. However, you can again start to see this pattern that areas in the Santa Clara Valley, Fillmore, Santa Paula, and then in the Oxnard Plains, namely Oxnard and Perquimini, have much lower rates of high school graduation. Similar pattern in the gray is bachelor's degree. The more eastern cities of our county, the more affluent counties have much higher rates of folks living with that have earned a degree, a bachelor's degree or higher. So just as education is a great predictor of one's health, so is poverty. And especially when you look at poverty and educational attainment together, you begin to see another pattern that is emerging. The green or yellowish bars are those poverty rates if you have less than a high school graduation. You see that your chances of living in poverty are much higher if you don't have a high school graduation. But then again, there's big differences in those poverty rates in the cities of, for example, Fillmore, all high schools does stand out in this one, but then the other ones, Oxnard and Santa Paula, have very high poverty rates for both the high school, those at less than high school graduation rates, but also with the bachelor's degree. Much higher poverty rates for those with a bachelor in the Oxnard Plains and Santa Paula area. Lastly, in terms of poverty stats that I'll share with you, Johnson mentioned how children, of course, is our future. We have to really address health disparities, health inequities among our children, and especially if they're poor and not getting a good education, is going to lead to poor health outcomes. And my next slides will demonstrate that. But basically, again, in the cities of Fillmore, Santa Paula, Oxnard, Perquimini, children, upwards of 35, almost 40% of children are living in poverty. Healthy beginnings, of course, we do want to focus on children's health. One indicator of poverty by school district is the percent of students eligible for free and reduced lunch. And you see that, again, in the Oxnard and the Santa Clara Valley school districts, upwards of 75% of children there are eligible for free and reduced lunch. So again, another proxy for poverty in those school districts. And so what is this leading to in terms of actual health outcomes? I just happened to choose obesity because it is a main risk factor for the leading cause of premature death and disability, which are chronic diseases. And so you see that in the same school districts, close to, if not over 50% of the students, fifth grade students in those school districts that I pointed out before in those cities are overweight or obese. And how are we doing as adults? Using, again, obesity as a proxy of the health of the community. This is by zip code, but you'll see that about 1/3 of residents in the Santa Paula and Oxnard area are overweight and obese, much higher than in the East County, the lower rates there. But even then, in the East County, and having the average of 20 to 25% overweight adults, in my opinion, is still too high. Real quick on the next slides, as I attempt to conclude here, is because cancer is now our leading cause of premature death and overall death, we do call out cancer in our report. And these are the top cancers, age-adjusted death rate. You see the lung cancer, female breast cancer, and prostate are the leading causes of death among those with cancer. This slide gives you a glimpse of the leading health conditions for folks on Medicare. And interestingly, you see that it's hypertension, almost or a little bit over 50% of those on Medicare have hypertension, Almost 50% of them have high cholesterol, have arthritis, have heart disease, or have diabetes. And a lot of these conditions, of course, are have a social determinant of health component. Our last area that we call out in our community health assessment is redesigning our health system. And I really, again, thank the Planning Committee and Johnson for having this summit, because it is only when we address our healthcare system and how we collaborate with our partners and how we engage the community that we're really going to make a dent in the health of our community. Health coverage still remains a big issue, especially when you look at the rates of health coverage and health insurance among Latino versus white. You see the Latinos are still very much underrepresented in terms of health coverage. And although this data is a little bit outdated, the rates are higher, but disproportionately still Latinos are much higher uninsured rates. Deleting preventable hospitalizations. So as a healthcare system, of course, we need to address preventable hospitalizations, and this is what we found in our report, that it's heart failure, bacterial pneumonia, urinary tract infections, diabetes, and COPD are among the leading top 5 areas for hospitalization. And some of these, again, lend themselves to interventions when we look at social determinants of health and we look at individual differences by zip code. So in summary, I hope that you can find a way, again, from what I highlighted or from our actual report, to utilize in your day-to-day planning or delivery of service, but also that you accept the challenge to further look into social determinants of health, because we believe that only then will we really have a lasting impact and to improve the population of Ventura County. So with that, I'll conclude, and thank you very much.
Rigo, thank you. And you see that Rigo's email is there and the link is there. Those of you who are within the system or are outside the system and are interested in looking at the entire report, I would highly encourage you to please look. It's full of wealth of knowledge. So I want to bring a couple things to your attention. Those of you who are new to the building, outside the door, straight to your right, are the restrooms in case you need. There's some drinks in the back. If you get thirsty, please do so. And I do want to apologize to Dr. Landing back there, who had a very important point to make, and I totally skipped her. So thank you for arranging for that. I do want to acknowledge a few people. It took a lot of effort to put this program together. And I do, in a few minutes, will tell you how this all came about. But internally, I do want to thank Adriana, Sheila, Dr. Lambing, and a few of the folks that helped put this event this afternoon together. So really appreciate it. Thank you very much. Our next speaker, Dr. Jerry Hoffman, has recently become our neighbor. I was joking with him earlier. Ventura is a beautiful place to be, and somehow he forgot that. And maybe the real estate agent is to blame. But Dr. Hoffman, for many years, was a professor of medicine at UCLA. He recently retired from there just a few months ago, correct? Yeah, sorry. Okay, all right. He was there on the full-time faculty since 1979. Dr. Hoffman received his bachelor's from Princeton University, went on to get his graduate degree from Columbia University, got his medical education at University of California, San Diego, and his residency in internal and emergency medicine at UCLA. He also completed his fellowship in medical toxicology, which is very interesting. If you look him up, he's very well published, and his publications cover a very broad spectrum of medicine. So please, I think moving forward, we will have him as a member of our team here. He's agreed to help me out wherever help is needed, which I many of you know I do need a lot of help, and I do appreciate that. So please look him up. He's very well published. Besides that, his love for teaching has taken him across many continents. He's been invited to teach in Europe, in the Far East, in South America, and of course here in the US. He has been a visiting professor to many different universities. Like I mentioned, he's very well published, so if you get a chance, do look him up. And without further delay, I would like to give you the speech class. Thank you.
Thank you. I'm really delighted to be here. Thank you, Johnson. I'm delighted to see all of you. We don't know each other, so I'm not exactly sure where you're coming from. And please forgive me if I say things that sound like they're old hat, or that sound like I need to explain myself better. But you'll help me out with that. I spent about 35 to 40 years teaching at UCLA in two different worlds, in the world of public health, at the School of Public Health, and at the School of Medicine. And it's always been amazing to me the different languages that are spoken in those two places. And let me just ask you, how many of you are frontline clinicians? Only a few. How many of you feel that you're more in the world of public health? Okay. So I guess what I'm really here today to do is to try to blend those two and to talk a little bit about taking this down from sort of an airy-fairy academic discussion about social determinants of health, but to realize that when Roberto tells us about that pyramid, where at the top there's clinical care, at the bottom there's sort of population health things, that the two are actually not that separate. And that in fact, what's important from a population level is also important on an individual level. And that it affects everything we do every day. And I'm going to try to tell you some stories rather than presenting slides. The slides that you just saw are very, very powerful, obviously. But rather than making this academic with a lot of numbers, you'll see from my slides that this is more something to get us to talk to each other. You'll see it from my slides because I don't have any slides. No numbers here. This is just to tell the story. One of the things that Rigoberto showed is something I was going to say right at the start. There's a famous saying in public health that you can tell more about a person's health outcome from their zip code than from their genetic code. And again, this is not just about populations, it's about people. And so I'll start off with a little story. I worked for a very long time at UCLA. It's a trauma center, busy, in the emergency department. That's what I did clinically, was emergency medicine. I also worked in LA County, I worked at Antelope Valley. These are some of the busiest emergency departments in the world. I've seen everything. You cannot think of something that I haven't seen. And people often ask me, what's a really great case? What's something really interesting? Let me tell you about a really great case, but it's a little different than what you might expect. And it didn't occur at UCLA or at LA County. It occurred at the Venice Family Clinic, where many years ago I was volunteering at their homeless clinic. And they brought in a patient, maybe in his 50s, I don't remember exactly. And I walked into the room and I could tell he was having a heart attack. It wasn't a very hard diagnosis to make. How could I tell? He was sitting on the bed, clutching his chest, making Levine signs, a very famous sign that said, "I'm having a heart attack." He was sweating, he was having trouble breathing. You looked at his monitor, he was having runs of ventricular tachycardia. That is, he was getting ready to die. He was very sick. It was very obvious what was going on. This was in the days before some of the things that we might do today. But in any case, we had a whole armamentarium how to take care of him. I knew how to take care of him. It wasn't that hard. And fortunately, we were there in time and made him better. So within a half hour, he was much more comfortable. He was breathing okay. His pain had gone away. He was in sinus rhythm. He was no longer looking really bad. And so I said to him, the next thing we have to do is we've got to get you to UCLA. We'll get you admitted. Venice Family Clinic had a deal with UCLA, even though UCLA is very expensive and the people at Venice Family Clinic had no money. they did have a special program where this person could be admitted to the hospital and get care. So I said, we need to do that for you, and he said, no. I said, what do you mean, no? He said, no, I'm not going to be in the hospital. Now, I don't know how many of you have seen patients like this, but I've admitted a lot of patients in my time, and there are often people who say, no, I don't want to come to the hospital. And you ask them why, and they say something like, I have to feed the cat. And usually you can work through that. But he didn't say I have to feed the cat. I said, you really need to be in the hospital. He said, I can't. I said, why? He said, my van is parked downstairs, and I live in my van. And tomorrow, after many years of waiting, tomorrow I have an appointment at downtown in LA with the housing department to get an apartment. I'm going to get an apartment tomorrow, and I have to be there. And I said, oh, wow, that makes sense. But, you know, it won't really do you any good to get your house if you're dead. And he said, if I don't get my house, I'd rather be dead. I've never forgotten this man. Fortunately, we had resources. The Vance Family Clinic was set up to do things, and we were able to help him and make it sort of work. We couldn't fix the bigger problems Rishi will be telling you about that are upstream from his house, but we could help him out. It was a very dramatic case, but not all cases that have to do with social determinants of health are quite as dramatic as that. But we see dramatic cases every day, and what I want to talk to you about now is a few of those. And I'm just going to tell you some that I've experienced, but you can think of many for yourself. So one of the things that wasn't mentioned up there, one of the social determinants, has to do with language and language justice. And language justice is the notion that you have the right to be able to speak to somebody who's going to help you in a language that you understand, or you can make yourself understood. And so we deal with this all the time. And guess what? In Ventura County, I'm sure you deal with it all the time as well. So I'll tell you a couple of true stories. You can, while I'm telling you this, you think of your own true story. So we had a patient recently I was presented who was getting ready to be admitted to the psych ward because we had a resident who had taken a history from him and said he was depressed. And the resident had some knowledge of Spanish and didn't really know very well how to speak Spanish, but enough to thought he could get by. And it's a real pain to try to get help because there's a lot of patients and people are on you all the time and you don't have any time. And so you try to do your best you can. And somehow the patient had said something about going to the Desperate. And I woke up this morning and he heard despair and he thought the patient was depressed and he started asking them in pidgin Spanish something about depression. The patient answered yes to a few questions about being depressed. And he got a psych consult. And in fact, it led to a fairly substantial delay in us figuring out what the patient had was a neurologic problem, which had absolutely nothing to do with depression. But just why was that? It wasn't because the resident was a bad person. The resident was trying to do his job, and the resident was trying to figure out what was going on with the patient. He was trying to speak to the patient, but didn't get it very well. We've had many, many examples of that. We had a patient recently where the resident was very pleased that in his pretty good Spanish, he was able to identify all the injuries that the patient had suffered and get the exact right X-rays and CT scans for a variety of broken bones. What he had not discovered was why the patient had these injuries and the domestic abuse that led to the injuries that put the patient's life at tremendous risk. I worked in France for a year during a sabbatical year, 25 years ago, and my French is really, really good. I'm pretty much fluent. And after a year there, I was really, really good. And I was always aware when I talked to patients that if there was something complicated about what we were talking about, I was worse than inept. Because I could say the words, but so much of human communication has to do with much more than just words. It's expressions and feelings and nuance. And unless you really are really fluent, it's your maternal language, your mother tongue, it's very easy to get fooled in language. So we have this all the time. A friend of mine just told me yesterday at a conference in Dallas that I went to on social determinants of health, a story about a patient who was in the emergency department, sent there from a nursing home because he couldn't stop crying. And after a long and fruitless medical workup, including CT scans and all sorts of other stuff, they couldn't find out why, they couldn't figure out why the patient was so sad and kept crying. And they also thought that the patient wasn't terribly with it because he was very non-responsive. Until this woman spoke to him in Japanese. She said, why are you crying? He wasn't non-responsive and non-verbal at all. He was crying because after his stroke, he developed dead sores, and he had a terribly painful abscess on his heel, which nobody had bothered to look at because all they saw was him kept crying every time they would talk to him. Now, these are sort of extreme cases, but do you think you don't see routine cases like this every single day? In this county, we saw that you have a lot of people who speak Spanish, and there's only 10% in that other category. But how many people in this county, certainly in LA, I know, we saw lots of patients who spoke Russian, Chinese, who spoke Farsi, who spoke 100 different languages. It's really hard to be able to speak in all of those languages. None of us can. But when we cut corners, which we all actually try to do, it's a busy job and there's lots of things to do, things get lost. It's not just about language. Related to language here, one of the other social determinants that we deal with here has to do with immigration status. I work in an ER, so what I see is probably less than what's seen in primary care offices. But how many patients do you know of, those of you who've done clinical medicine, how many of you have you seen patients who had some sort of skin infection, a cellulitis, or a little abscess, and kept coming back? I've seen lots of patients keep coming back. Why? They failed their antibiotics. And somebody wants to put them on a new antibiotic because the old antibiotic didn't work. And what didn't they figure out? They'd never taken their antibiotic. And why hadn't they taken it? Because they couldn't afford it. Or because they didn't understand the prescription that was written there. Because when they're given follow-up instructions, nobody really talks to them in a way that they understand. Or they did take their antibiotics, it still didn't work. Why? Because they didn't put their leg up. Why didn't they put their leg up? Because they had to go to work. Because nobody was going to pay them if they went home. It's like, or maybe they didn't have a place to put their leg up because they were homeless. I don't want to make up a number, but I've seen thousands of patients with some variation of this thing. And why is it important? Because if you don't figure out the real reason why they're failing, you can't help them. It's not just a population statistic, it's the patient in front of you. We have lots and lots and lots of patients where to solve their problem, you cannot do it without addressing some of the social determinants: food insecurity, poverty, inequality in wealth status. There's a huge literature, you saw little of it, but there's a huge literature testifying to the fact that the number of CT scans you have access to has a very, very, very small effect, at best, on your likelihood of a good health outcome. But the country you live in, how much income inequality there is in that country, has a huge effect on that. It's not just income inequality, it's all of these other things. There are a bunch that you heard about, there are a bunch you didn't even hear about. So parks to walk in, and food, healthy food, not fatty food that's expensive, which is a curse of many of our poor neighborhoods in the United States. What's called the justice system, the criminal justice system, and its effect on populations, massive. If we want to really care about our patients, not just the population, some nebulous thing out there, but the patients in front of us, we have to deal with these things because they are a much more profound impact on health outcomes than MRIs. And I say this not to diss the sick care system, which I think is really important. I worked in emergency departments where I saw really, really sick patients. And you can do wonderful things. That's the tip of the iceberg. Mostly it's not about that. So, I'll tell you one last story, and then I'll sort of wrap up because I don't want to take too much time. But the last story is a patient who was seen at a hospital not to be named, where he was admitted 6 times for rule out MI, rule out acute myocardial infarction, rule out acute coronary syndrome. He was 26 years old and he was having chest pain. 26-year-olds do get cardiac events. It does happen occasionally. It's very rare. It's not a common thing. This guy kept coming back with chest pain, and he kept being admitted and getting all these tests and then saying, well, we don't find anything, you're okay. And what they never did was figure out that when did it all start? It all started, he had escaped from El Salvador, where he was being chased by a gang that wanted him to participate, and he didn't want to participate. He came to the US, and then he got word that they had targeted his family back in El Salvador. And there was nothing that he could do about it. And he felt helpless, he started having chest pain, started coming to the ER, and kept getting admitted. Nobody had bothered to figure that out. Now, why do I tell you that as the last story? Because I want to remind you that it sounds like when you hear a story like that, like, why are you making my life worse? What am I going to do about that? I can't go fix the gang in El Salvador. You know, these are problems that are far upstream, as we will be talking about, that we're not going to have easy solutions for. But the reason I tell you that is because it's not just that if you want to know what's going on with our patients and what are the root causes of many of their health problems and their health outcomes, you have to know these things, but because it isn't hopeless. I don't think any of us, alone or together, can fix the problem. It's a big problem. There are huge social problems in our country and in our world that are bigger than both of us, as Jackie Gleason used to say. But that doesn't mean we can't do something about them. So there are many things that can be done, and there's pretty good evidence. I'm not going to show you the evidence. There's pretty good evidence that if you really want to help health outcomes in populations, which means in individuals as well, you have to have things like what they did in San Francisco when the current director of the Los Angeles County Department of Health Services was up there. We took money that the supervisors thought was going to go for MRIs, and he put it into housing for people who couldn't get housing. And by the time they found out about it, they couldn't do anything about it because he was able to show that they had decreased admissions to the hospital, deaths, every sort of measure you could have, and saved a fortune of money. It's not just that program. There are many, many, many programs which show that if you pay attention to social determinants, things like having a social worker in your department or in your clinic. Social worker can help people fill out forms that they don't know about, can get them enrolled in Medicare Medi-Cal that they don't know about, or in some other program for immigrants, for undocumented immigrants. A community health worker who can help them get to their clinic appointments because they keep coming back to the ER, not because they're stupid or because they're non-compliant, but because they can't take time off for work and nobody's made them an appointment when they can go. You can have a program which has community health workers who are relatively inexpensive to do a phenomenal job of helping people navigate a terribly complicated and crazy system. You can have pharmacists who know about programs to get medicines that are cheaper, even though I wish I could say cheap, because there's no such thing. But where they can actually get access to medicine, and a million other things like that. And legal aid for that immigrant whose family is in El Salvador. Because there often are things we can do, despite the best efforts of our government, to help people who are in need. So we can't all do everything. Some of us are going to be just clinicians, and some of us are going to be working on data sets, and we all have different jobs. We can't all fix this, but some of us, we have to know what all of us can do. And the first thing we can all do is pay attention to it, and teach ourselves about it, and teach our colleagues about it, and our friends about it, and make it part of the language that we talk about. It's finally being talked about in medicine. In the School of Public Health, they have a whole division on social determinants. In the School of Medicine, most of my residents had never heard the words. We can talk about it. We can learn about it ourselves. We can ask our patients about it. Some of us can be advocates. I'm here because Johnson is trying to make changes so that you guys will be able to more effectively address these things. And I want to help with that. I think that's really important. We can all advocate on every level, in our hospital, in our group practice, in our emergency department, in our Department of Public Health, or wherever it is. We can go to the state level. There's different things that all of us can do. Sometimes it's discouraging because we live in the real world. And these are big problems, not easily solved. But that doesn't mean we have the right to give up on them. And the good news is that if we don't give up on them, then we'll have meetings like this, and we'll all put our minds together, and I won't tell you what to do, we'll figure out what to do. Because there are things we can do that really make a difference. And there's evidence, there's lots of evidence for that I could present to you in a different type of meeting. So that's my challenge to you, is to go forward with this and to think about why addressing social determinants is the most critical job we have as healthcare providers.
Thank you for sharing all those stories, and stories are very important. And I hope that you paid attention to every word that was said, because there was a lot said. There was a lot said. I think talking about different models of delivery is critical. I see a lot of the physicians from our system in the room, and I do want to thank them. Dr. Gonzalez is back there. Dr. Wong is here. Dr. Lava is here. I saw Dr. Cho earlier. Dr. Patterson is here. Right there. And I'm sure I'm missing other physicians, but the amount of work that we are asked to do, or are asking our physicians to do, is very difficult, very difficult. But Dr. Hoffman mentioned a couple of things, I think, which we in our system are utilizing, but I think we could do a better job. If a community health worker can gather the information necessary to inform the provider of aspects of person's life that are negatively impacting, I think we can make a bigger difference. How many of you know about the model? This model I learned in the 80s, going through public health school. The collective impact model. These are all MPH people. I wish there's an MPH person. So the basic thing I remember from the 80s about this model is, how would you define it in a few words, what the collective impact model is?
Thank you, Johnson.
No problem. She's eating my lunch.
Working together, we can achieve more than we can working alone.
Okay, that's exactly what I remember. Working together, we can achieve more than we can achieve alone. So the word collaboration was repeatedly, Dr. Andy Heinel was my professor. Dr. Andy Heinel kind of drilled that into our heads. So here today, besides the healthcare agency, there are a few other community partners that we have. And I do want to challenge, the solutions that we're looking for are not, I said it earlier, are not with only the physicians or other healthcare providers. We do need to come together as a community to solve these issues. Now, I would like to introduce you to Dr. Rishi Nanchanda. Some of us had the privilege of listening to him in person. Last year, it was at the CAPH annual conference. Others have listened to him in different settings. Those of you who like TED Talks, he's on there as well. He's written quite a bit, so I am privileged this afternoon to have him here and to introduce him. Dr. Nanchanda is a physician leader, health system innovator, and author. He is president of Health Begins, a social enterprise, and provides healthcare professionals with tools and support to improve care and social factors that make people sick in the first place. Dr. Nanchanda has led healthcare systems in different settings. He has been a chief medical officer for a large self-insured employer, a lead physician for homeless primary care at the VA Greater Los Angeles Healthcare System, and the first director of social medicine for a network of community health centers in South Central Los Angeles. In these leadership roles, Dr. Manchanda has led transformation efforts and built cross-sector clinical and community programs that have improved health outcomes in vulnerable communities by focusing on health-related social risk factors such as homelessness, slum housing, and food insecurity. In his 2013 TED book, The Upstream Doctors, he introduced a new model of the healthcare workforce that includes upstreamers who improve social determinants of health. Dr. Manchanda earned his bachelor's medical degree and his master's in public health from Tufts University and was the first graduate of UCLA's combined internal medicine and pediatric residency. Thank you, Rishi, for being here.
Hi, everybody. Jonathan, thank you to everybody here. Thank you so much. Let's get some blood flow. Stand up for a second. I invite you to stand up. You can stay in place. Go ahead and just yeah, twist a little bit. There you go. Twist that way, to the left. Get some endorphins flowing. Look to your left. Look to your left. If you have some to your left, smile at them. If you want to your left, come to your right. You figure it out. And then the front. Big stretch up in the air right there. Take a big deep for Ventura. Thank you. You can stay standing if you like, but you're welcome. It really is a privilege to be with you guys today. It's a very embarrassing thing every time I see you bio and you think, wow, that went to my mom first. So thank you for that intro. I really wanted to make sure that we're building on the momentum of the conversation so far today. And let me stand over here. For those, can you all see if I stand over here from the screen? So you can see me. The screen is probably more important. All right. So we're going to learn first about what this means in day-to-day life with a really expert kind of grounding and story that Dr. Hoffman shared with us in the first day, from Roberto, and the work that obviously each of you brings every day. I wanted to just orient ourselves first to the quadruple aim. So show of hands, triple aim. Who's heard the triple aim before? All right, so triple aim represented by the top three aspects there, right? Improve the experience of care for patients, make sure that you're improving outcomes for populations of patients, and try at the same time while you're spinning those two other plates, reduce per capita costs. Good luck, right? Oh, by the way, the fourth aim, make sure you're happy while you're doing it, okay? Be joyful. Obviously, these things we don't take lightly, although we should, because it's hard otherwise to keep them up and going. Spinning each of these plates individually, if not all four at the same time, is a pretty difficult task, right? Not just for administrators and leaders, but for each of us every day, in whatever role you're playing. Public health, social services, healthcare delivery, in any role that you're playing right now, it's hard to spin all those plates at the same time, and particularly now when you hear about the health inequities that are outside the walls of our clinics or our hospitals or our practices in the community. When we think about those things, how do we actually achieve any one of those quadruple aims while keeping our eyes on what's happening outside in terms of equity, this deep sea of blue against which we operate, right? These questions of structural opportunity, of fairness, decision-making. Let me give you a quick example of what this means. Shared decision-making, is that a concept people have heard about? Shared decision-making. Someone just quickly shout out what that means to you. Shared decision-making, what does that mean? This is going to be a lot of call and response. I might go Phil Donahue style into the audience here. So, shared decision-making. I saw somebody's hand. Involving patients, good. Collaborative, good.
Patient-centered.
Patient-centered, good. And it's about, in a collaborative way, involving patients making a decision. Right? Good. What's an example of shared decision-making in the community? Because right now we're using the context of what's probably happening in an exam room or in a hospital. Right? What's a classic version of shared decision-making in the community? We do it every 4 years. Sometimes we're often voting. Right. We have shared decision-making in the community, and sometimes our jargon prevents us, as Jerry was saying earlier. Sometimes we talk about similar concepts: engagement, involvement. I have a voice. I want to be heard. Well, we have iterations of this, and for our community partners, for folks who are involved in equity and advancing justice, civil, political, and social rights, and for those who are advancing the rights of patients inside the walls of our hospitals, it's time we start looking at least each other's work in ways that have similarities, and so that we can cross-pollinate, learn, and avoid some of the artificial silos that get created sometimes because with the professional degrees that we all work so hard to get, we sometimes learn the downsides of silos, right? The downsides, which is we assume that, I talk about shared decision-making in the exam room, but I can't talk about what it means in the voting booth. We need to learn about ways to talk about equity in a way that is as facile as we talk about things about when we spin those plates. Fair enough? So level set, quadruple aim, equity. Having said that, let me kind of follow Dr. Hoffman's lead and ground us with a patient. So this is a stock photo. I'm not sharing any PHI. I haven't violated anything yet. It's a stock photo, but it represents the story of Mrs. M. And Mrs. M is a composite story that is based on a real patient that I've had the privilege of caring for, and I imagine this story resonates with some of you. Mrs. M is a 46-year-old mother of 2. She is living with type 2 diabetes. She also cares for her elderly mother, who is frail, stays with her at home. She's balancing the care of her 2 children, her job, and her the needs of her mother, while being a proud, dignified person, right? Member of the community. She's like you, someone who is making ends meet, taking care of your family, put food on the table, and when you have time for your dreams and your hopes, when your head hits the pillow at night, you think about, okay, did I get one step closer, right? You try to work through the good days and the bad days. She's just like, something happens at work where she gets insurance, health insurance. She pays about, by the way, just a little bit more context, she pays about $1,200 a year out of pocket for healthcare costs. That's on top of the employee premium that she's contributing, about $4,800 a year, which is around the national average, not including the employer contributions. So she's spending money on healthcare. She's insured, but she's trying to make ends meet. Something happened at work. Her coworkers noticed that she was feeling really dizzy. She actually nearly fainted. Her coworkers got really concerned about her and called the paramedics. And they brought her into the hospital, not unlike this vehicle. So, okay. So far, stories seem somewhat familiar. You can see yourself now, first in Mrs. M's shoes, bouncing this out. And now you found yourself that person. Imagine that sensation. Anybody faint ever or nearly faint? Remember that visceral reaction. It's a deep reaction, right? The queasiness. And now you've awoken and oriented yourself and you're in the emergency room of the local hospital. And a workup happens, and the doctors and nurses and medical assistants and others come in and out of the room. You know that feeling, right? You tell your story about 14 times to the different people, and you find yourself getting admitted. Before you know it, the diagnosis they come back with is saying, Mrs. M. And the young doctor who walks in the room proud of himself that I figured it out, and communicates that diagnosis, says, I figured it out, Mrs. M. You have hypoglycemia. You say, I'm sorry? He says, I'm sorry, low blood sugar. And you, like all of us, are thinking, what led to that? How did that happen? Low blood sugar. I'm a diabetic. My blood sugar, I was told, runs high. So we're all deputized now. I don't know what the patient rooms are like in the hospitals that you guys operate, but in the patient room that we're now in, it's big enough to accommodate all of us. All right? This is it. It's a private room. It's UCLA. Mrs. M is right here in front of us. And we're all now wearing our degrees, whatever uniforms represent our degrees and our training, and we're all deputized now as part of our care team. And I invite you now all to answer this question. Again, call response. What could have led to Mrs. M's hospitalization? Shout it out. And there's no wrong answer.
Not eating.
Not eating. Great. Keep on going. And
Stroke.
Stroke. Excellent. Keep going.
Infection.
Infection. Good.
Fatigue.
Fatigue. Fatigue. Good. Fatigue. Thank you. Stress. Good. Let's take stress. How would stress manifest in this way to lead to low blood sugar, symptomatic low blood sugar?
Medical condition.
That's okay, yeah.
The fact that she's got a sick mother at home that she's sending to, the fact that she's got children that she has to worry about.
Yep. That's some stress.
The
Yep.
work I'm worried other conditions.
Good.
And I think, I don't know
Yep.
culture here, but sometimes, mothers and fathers will look out for their children and other family members before they look out for
Yes,
themselves.
I think that's a universally true thing regardless of culture. Right? I think that's absolutely true. Yeah, exactly. Stress, competing priorities, feeding your loved ones before you feed yourself, especially if you're a mother. Very true? Good. Anything else? Medicine? Dr. Hoffman says underspread medicine, right? So tell me how medicine could have led to this. Sure.
Maybe she's so preoccupied, maybe she took too much of your medicine.
Good. Took too much of what type of medicine? For insulin. Great. What else?
Stopped monitoring.
Blood pressure.
Blood pressure medicine, stop monitoring. Good. We've done a great job with, in the medical world, we say differential diagnosis, and public health and other sectors, we say root cause analysis, right? We've essentially tried to brainstorm a couple of ideas, and if we spend another 5 or 10 minutes longer before we walk in a room, we'd be able to come up with a rank order, right? And say, here's what we think is led to this, and here's the tests that we want to implement to verify our hypotheses and go forward. Sound good? Can we do that?
Yes.
All right, let's go for it. All right, so let's see. First, some of you guys, and Dr. Hoffman mentioned this as well, some of us, let's try to classify the way we thought about this, the process we used. With the talent and the brain power and the expertise in this room, let's categorize all of this immense kind of background into a way that allows us to understand what we just did. Some of us actually, and maybe each of you guys, instinctively thought of Mrs. M as a person, biologically speaking, her constitutional factors, her age, her sex, her background. You thought maybe something happened to her being, physiologically, the organism that her body represents, right? Something happened there to dysregulate something. Maybe the medications that she took, like insulin or another blood sugar lowering medication, sulfonylurea or something else, right, led to an adverse drop in blood sugar. Maybe she's got an insulinoma. Maybe she's got something, a stroke, something else that totally threw her insulin metabolism and glucose metabolism out of whack. Right? And if we aren't thinking about that, then we're probably not doing a good job as a hospital. Because we should be thinking first and foremost about what's happening there. But obviously, while that's necessary, it's insufficient, right? So some of us actually started saying things like stress and eating, skipping meals, food. We started talking about how she was eating, how she was exercising, how she was sleeping, etc., right? Behaviors. So if the first bucket of potential causes was biology, the second is behavior. Fair enough? All right, and partly because I think of the prime to pump phenomenon that happened in the last 2 hours, some of you may have been thinking, well, maybe there's something else that this guy's asking me to think about in this blue outer realm here of living and working conditions. How many people actually, did you hear anybody say food insecurity, specifically that term? Well, I invite you, if for nothing else today, if I accomplish nothing else, then I invite you to start thinking with more rigor, the same rigor that you demand of yourself, of your professional degrees, the things that brought you to this room to be part of this community. I invite you now to raise the bar of expectations and say, with the same rigor that allowed me to think of biology and behavior, I'm going to think about food insecurity and other social needs. Because frankly, not thinking about food insecurity or other social determinants with rigor and precision is providing substandard care as a group. If we think about it loosely, it's kind of like we're loosely taking care of system, right? We're loosely thinking about ways to consider this. It's time for us essentially to start thinking about these upstream factors, and I'll go into more detail about this in a second. So food insecurity. Let's talk about food insecurity. Just for an example. We've heard there's so many different social determinants. I'm going to do a little deep dive here with Mrs. Hemmetzer-Christa. So food insecurity is a household level phenomenon. USDA and others have actually defined it. When a household doesn't have enough food to be able to afford healthy food, that is food insecurity. What is an individual level manifestation of that? What do we call when somebody who's in a food insecure household doesn't feel like they have enough food? Hunger, right? Like the sign when you have a heart attack. Same kind of sign when you're that child and you're rubbing your belly sometimes, right? Hunger is the individual level physiologic manifestation of food insecurity, right? And I mean hunger. I don't mean I want another donut. Hunger, right? This is about that hunger, and hunger comes and goes. But you can have hunger without food insecurity, right? You can have food insecurity without hunger. That's an extra point for learning objectives and the CME thing. You can have food insecurity without hunger. You know that? Can't, right? There are food insecure households. Turns out there are 1 in 7 food insecure households in America. Okay? 1 in 7 households in America are food insecure. It doesn't mean like everybody's walking around holding their belly with hunger. It means that they're living in a tenuous situation. It turns out that food insecurity, even after controlling for income and socioeconomic status, independent of those things, has been linked to as a risk factor for the development of diabetes. So if you're in a very food insecure household defined by the USDA, you have 3 times higher risk of developing diabetes than a food insecure household. Wow, how is that? Some of the emerging science indicates that it might be that the feast or famine phenomenon, when that unhealthy food, the cheap, nutrient-poor kind of food comes in there, that energy-dense, nutrient-poor food that you're taking, right, comes into your body and it throws your insulin for a wild ride, it spikes and goes down. That roller coaster ride of insulin metabolism that you're putting your body through and all the other kind of cascading events of hormone dysregulation, as that kind of goes haywire, that pushes and pulls and pushes and pulls your pancreas to the point of exhaustion. This is the working theory. There's more science to you know, to look at this, but what does it mean if food insecurity in and of itself is a risk factor for developing diabetes? And we look again at those kind of preventable differences, those inequities in Ventura. Let's bring some more to home for our hospital partners here. Based on literature and research performed in California, published in Health Affairs in 2014, a beautiful study by Dr. Hilary Sullivan and her colleagues at UCSF demonstrated that low-income diabetic adults have almost a 30% higher risk of being hospitalized, not just in the ER, but hospitalized at the end of the month compared to food secure households or high-income non-diabetics. In other words, let me translate this. If you are experiencing end-of-the-month food budget exhaustion, right? You sit there, you're Mrs. M, you got money enough for rent, you got money for the meds, you got money for other costs, your mother's medications, and then you have food. We just heard, you feed your children, right? You maybe skip on your meal, but you do actually what we all expect. You actually adhere to the recommendations of your doctors and nurses. You take that blood sugar lowering medication as prescribed, that insulin or that sulfonylurea or something else that hasn't been corrected for your food security, right? You take that thing that you're supposed to be taking according to your doctor. You have no food in the belly. The blood sugar lowering medication lowers the blood sugar. And voila, you have now low blood sugar. This increased rate of hospitalization is not for hyperglycemia or high blood sugar. It's for low blood sugar. We have a phenomenon of preventable hospital admissions due to food insecurity manifesting as low blood sugar. If there was ever a low-hanging fruit in terms of something we could address and prevent, right? This is it. What's the treatment for malnutrition? Food. Anybody prescribe food? Anybody? Looking for my doctors and my nurses, especially on the medical side. Anybody prescribe food?
They always have a dietitian go in and talk about it.
Good. Can the dietitian prescribe food? Public health friends? Somebody said WIC. Right. WIC is a vehicle. It's a food pharmacy, if you will, in the community, right? How do you dispense WIC? Your cards, right? Doctors and nurses and others in the hospital system and the healthcare delivery system. There is a pharmacy that exists in the community. It's called WIC, and there's CalFresh and other programs. There is a pharmacy, there are prescribers who are experiencing patients that are out there, but we don't have mechanisms to prescribe it. Is this a problem we can solve easily? Do you know how to prescribe other things? Yes. In other words, we can work this out, right? So these are preventable issues right now. So let's talk about what this whole story is about, right? We know that health begins upstream, right? We've heard about this really expertly from Rodrigo, from the stories about Hoffman. We have to acknowledge that it's not an either or, right? It's not public health versus medicine versus social services. It's really, if health begins upstream, then sickness does too, and therefore we're all in this, right? We've heard the stories. Sickness starts upstream also, right? As Mrs. M's story delineates here. And let's say that Mrs. M wasn't compelling enough of a story, or the stories you heard from Dr. Hoffman weren't compelling enough, or the statistics you heard early enough in that the story what was happening with our public health conditions wasn't compelling enough. Let's just think about what it means if you read this and it resonated with you. Can I invite somebody just to read this out loud? Somebody in the middle of the room, if you don't mind. Anybody to volunteer?
I'm a position
Thank you.
in a rural county. Meth addiction, municipal dropout rate, many more issues. Understand upstream approach for years, try my best, but it falls by the wayside as I don't have resources. No help, city, county, overwhelmed. Patients lost to follow-up. I've seen over 30 a day. How to manage, would like to discuss.
Thank you. What was your name?
Rebecca.
Rebecca, thank you so much. Round of applause for Rebecca. Anybody ever see an email like this or feel like this? Does this resonate with anybody in this room? You don't have to raise your hand. Somebody did. I got this email about 3.5 years ago from a pediatrician in a county a little bit further north of us, here in California. And there's two thoughts immediately that came to mind. One is, wow, she is so busy, she can't even type in complete sentences. Right? Picture her there between patient 26 and 27. She's like, what do I discuss? And the second, of course, feeling right away immediately was, I know the professional code for help is this. Would like to discuss? Don't bother me, but help! This is a person in pain, right? This is a colleague of ours in the health system who's in pain right now. Providers are hurting right now, and there's a lot of literature demonstrating the direct correlation between the ability of the health system to be able to address upstream issues for their patients and the burnout rate among its workforce. If you're working on other fronts to try to improve joy at work and improve recruitment, retention, and address burnout among your professionals, part of the solution is based on the science and based on common sense about providing a capacity to move upstream to push through these silos. So if it wasn't enough for patients like Mrs. M or providers like that physician to say this is important, it's also important because the payers are starting to say, pay attention. Right? Medicaid managed care organizations, as this report has demonstrated, and others are making investments now in social determinants. You have payers, companies, Medicaid managed care organizations, commercial folks, and others who are essentially saying, let's move upstream. So the point is something that you've now come to believe, hopefully after 3 hours of listening. You can't move upstream, you can't address the quadruple aim, without moving upstream, without addressing social determinants. Can we get an amen on this point?
Amen.
Can we get a bigger amen on this point?
Amen.
Now, when you go out into the community right now, don't forget this point that you just actually agreed to, right? That consensus is important because not everybody's on the same page about this. People fall victim to siloed thinking, right? They do this sometimes. So please, at the very least, make sure that we're communicating this point. If you're thinking about joy at work, lowering per capita costs, improving outcomes, improving the experience of care, or frankly, just making sure we have justice and equity in society, we got to at least in part be on the same page about moving upstream. It's integral to our work. Yes? All right, hopefully you're all feeling like this right now. This part, sorry, this part. You feel like this right now? Are you frustrated enough? I get it. Social determinants matter. To us in healthcare, the social services sector, CBOs, and public health. All right, so if that's the case, then we're now at a point where many of our patients are every day. When a patient walks into a healthcare clinic, or when a person walks into a WIC agency, or when someone walks into a behavioral health facility, when someone walks into any one of the service points that we provide, and says, there's something I want to do. I want to quit smoking. I want to exercise more. I want to lose some weight. I know I got to do something about it. I'm not so sure. What methodology do we use? What's the technique that we use when we try to help that person who knows that they want to make a change, isn't really sure about making that change? Motivational interview, right? I'm now your motivational interviewer for today. Because we are all in the healthcare system, and the health systems at large, at this point. We know these issues matter, we just don't know how to get there. So instead of, I don't think when somebody wants to quit smoking that you say, let's talk about tobacco tax policy. I mean, if you do, it works, but we say, hey, your toothbrush, you keep it in the medicine cabinet right there, maybe that's where you put your chewing gum instead of cigarettes, and that's your reminder of actually how to get, a little bit, or you put your Nicorette there. Right? We use techniques that are small, actionable things, and we build confidence and efficacy. Quick time check, how am I doing on time? I have another 15, 10 minutes?
17 minutes.
Let me give them the whole thing, yeah, 17 minutes, perfect. And you guys, if you want to bum rush and take them on the stage earlier, happy to oblige. So far, so good?
Yes.
First thing we got to do, I think, in terms of moving upstream is to start with the story. Because we can't talk about staffing and software and other system changes without actually reimagining ourselves.
And there's so many stories that abound. I'll share with you one that I started developing to tell myself what I wanted to be and what I wanted us to be in the healthcare system when I was working in South Central Los Angeles at Inequities. And I used that same story, that parable, when I went to the VA working with homeless veterans. I used that same story working in the Central Valley with an immigrant workforce of employees and first generation, second generation immigrants, and thinking about how to communicate social determinants of health. And the one thing I learned is when we're working, when we're out in the field, out of this room, here it's okay. Social determinants are okay. I highly recommend that you don't say social determinants outside this room. Unless you're, you're at Thanksgiving dinner and sit with family and they say, oh, there he goes again, talking about social determinants of health. Instead, grab people by the hearts. Tell a story. For this story and telling, I need 3 volunteers. You don't have to do anything except for volunteering your hand and your name. So somebody in the front of the room, from around here, someone I don't know, yes, ma'am. Elaine, thank you. Someone in the middle of the room. Somebody, yes, ma'am.
Sarah.
Sarah, thank you so much. And Sarah, let's go, somebody way in the back there. Yep, yeah, Simone. Elaine? Sarah? Simone. Elaine and Sarah. Thank you. Okay. Let's all come up and do an interpretive dance now. The 3 of you right now, Elaine is like on it. You can see. So Elaine, Sarah, and Simone now see this beautiful setting. It's post-drought. We're all set. It's fine. Beautiful river. Right? Something horrible happens, of course. You see people in the water, right? 3 of you see this. And now the rest of us now who've gathered along the banks of the river see this. We see what Elaine, Sarah, and Simone see. We see people in the water. Now, they're not just, in my beautiful artistic rendering, just dots on the map, right? Those dots are people. They're children, the adults, the elderly, and they are shouting out, Elaine, Sarah, Simone, everybody, anyone who can hear me, help, would like to discuss. But these are our patients, right? These are the people we serve, our clients, our patients, our beneficiaries, our constituents. And they say, help. And Elaine, Sarah, and Simone, what do you guys do?
Jump in and help.
There you go. That was great. So you jump right in and help. And the rest of us say, hey, that's great. Exactly. Let's cheer them on. Great job, guys. Thanks for jumping in. They're saving lives, right? Let's applaud these guys. Applaud. Please. Elaine. Elaine is a really strong swimmer. Not only am I up for a dance, I'm also swimming. I'm a really strong swimmer. I'm going to go to the water's edge. There's a waterfall out of sight here, and I can see people about to drown. I'm going to rescue those about to drown. Right? Now, the rest of us say, Elaine, that's a great idea, right? Should we applaud the rescuer? Yes. Sarah says, wait, Elaine, I've got an idea. Let me kind of, you continue doing that. I'm going to swim a little bit further upstream, and I'm going to coordinate some of the branches along the banks of the river. I'm going to build a raft and usher more people to safety. Sound like a good idea? Good, let's call it PCMH. Quiet, please. Let's get level 3 certification for that PCMH, and then let's patients in a medical home for the walking out a little bit. But in other words, that's primary care, right? Raft building, clinical preventative services, ushering people to safety. It's not just primary care, it's actually what a lot of care management tends to be. Making sure that you're taking care of a panel of people and ushering them to safety so they don't need to end up in rescue all the time. Now, not to Elaine and Sarah, but to other people in other rivers, in other parts of the state and the country, they get a little, those people get a little tired, right? The rescuer, the raft builder in other rivers, they start getting a little fatigued. They say to people in the water, come on, you again? I mean, didn't someone teach you how to swim? Out here again for that blanket? Right? They start, ugly things are coming out sometimes. You can hear it. Like they start going, you're just not a compliant person. Start talking to each other about, they start describing the story of that person's life in the water as if they know that person, but they get blinded to the realities and context about their own stuff. Not Elaine and Sarah, because these guys, much like all of us, remain committed. They redouble their efforts. They are full of nobility and honor. They do the work of saving lives. And yet they realize something. Wait, there was a third friend. Simone? Where are you? Way over there. Hey, Simone. And they shout like the rest of us now shouted. Where are you going? There are people here to save. What's going on? I mean, out of real despair, right? Because you're slogging away. You're rescuing, you're raft building, you shout out, Simone, where are you going? There are people here to save. And Simone says, I know. Now she's in the water. She's saving people as she's going. She's not pontificating like I am now. She's doing the work. just like these other two are. But as she's swimming away from them upstream, she looks back over and she says, I know I'm going to find out who or what is throwing these people in the water. I fashioned myself not just as a specialist or a rescuer or a comprehensivist, like a raft builder or a primary care person. I try to fashion my career as the third friend as an upstreamist. And I don't think all of us have to be upstreamists. I just think that we need a specific, rigorous component of the workforce in every system that is thinking about how they can improve the work of our raft builders and rescuers by thinking about how we can systematically, routinely, regularly think about food insecurity for Mrs. M, or housing insecurity for Mrs. X, and so on, in a way that's driven by data, with rigor, with collaboration, right? We've always had the upstreamists in the workforce. We've always had them. In the healthcare workforce, we always had them, and we've always had them because everybody realizes in common sense that in the healthcare system, when you have those upstreamists, those are the folks who actually are the ones that the public health department and the social services department, they know that's the person I'm going to call if I want to actually get through that project. They're the champions to make it happen for the system, right? It's time for us to actually formally acknowledge that role. And I think about how the upstreamists in the healthcare system can partner up with upstream partners, including those represented here today. This is not an either or, either public health or medicine. This is about having a smarter story. And a story that recognizes that, frankly, as Rita was sharing with us today, it's about the entire ecosystem. This another article from Health Affairs shows that the more system capital that you have, the more your population health system has connectivity between the healthcare and the public health and the social service partners, the more at a county level those connections exist. County by county, the more connected you are, the more system capital you have, the longer people live. Look at the all-cause mortality here. In systems that actually had comprehensive system capital in communities and counties that had this, people live longer. The death rates were higher in places that didn't have it, and lower in places that did have the connectivity. So this is life-saving, right? The connectivity that you guys are accomplishing here today, the work that's going to continue going on after today, the work that's led into today, this is part of the solution. It's not just about individual, it's about all of this buildings together, because that's what saves lives. Problem is that it's hard sometimes to build life-saving capital on a lopsided foundation, right? We have to acknowledge the truth, the real politic of this. And in this country, for the past many, many decades, regardless of political affiliation, we've all done something somewhat absurd compared to our peers. In every other industrialized nation in the world, the amount of spending on social services is higher than the amount of spending on healthcare. In our country, we've actually done more on healthcare than social services. And regardless of who's to blame for this, what that has led to is actually a lot of resources in our healthcare side of the house as a nation, and very little in the community, right? When we move upstream, we have to think about how we can build capability, level the playing field, because not only are there population inequities, but there are structural inequities between the systems that are represented here. I'm not saying anything out of turn. I think I'm saying something that probably resonates with all of you. But I'm saying it in the spirit that brought you together today, which is to say, we can do this. Let's do this in a way that actually makes sense. Let's think about how we can build the capability, acknowledge inequity, and try to build it towards a system that actually can save lives. So how are we going to move upstream? I think to translate this, this is based on work that I've been doing for a little bit of time, and particularly in the past year with organizations like CMS, Centers for Medicare and Medicaid, and the American Hospital Association, and a few other health systems in California and other states. Health systems now are saying, just like you guys, let's do this. How do we operationalize it? So here's the operational roadmap that we suggest. First, get ready, get set, go. Now, there's actually some theory of change behind this. The theory of change is that organizational readiness is a big part of what we look at. And for us to actually get ready, we have to think about how to evaluate our readiness to move upstream, just like we did for other business changes. In the healthcare sector, in the public health and community sector, we actually can evaluate what's our strength and our weaknesses when it comes to certain specific domains. There are a lot of different assessments now that are cropping up. This is a domain map that we put together to be able to evaluate readiness and to answer some questions with some rigor. This is just a domain map. There's about 64 questions that are behind this one. And there's other ones that are out there. But the point is, check your pulse as an organization. If you're part of this collaborative, think of your own organization in this room and ask yourself, have I taken my pulse? Look at different domains of readiness. everything from HR infrastructure to project management capability, but not generically, but specifically for food insecurity for Mrs. M. Right? Are we ready? Because if we do that, then I think we can start to assess what we need to get set. We should not go about this blindly. We should not talk about tobacco tax policy when we actually want to quit smoking, right? We need to have rigor. And after getting ready, then we can get set. And part of that means let's identify our Simones. In our healthcare system, in our public health sector, in our social service sector, in our legal aid sector, we have to identify the people who are our internal upstream champions, our students. And then who's going to be our community partner in this case? So what's a good example of a community partner we should contact to help Mrs. M who's experiencing food insecurity related hospitalizations? Food bank. Is there a food bank in the room?
Not here.
Not here, but they'll be here.
Yeah.
Can you name a food bank?
Food share.
Food share, great. Anybody have food share on the speed dial? Great, so you know. Right, so food share. Let's talk about food share or anybody else in that same space. And identify with the food bank one upstream opportunity, one home run opportunity. So how do you identify home runs? In general, in life in general, how do you identify a home run? You see it out of the park. I mean, you think about baseball, you see a home run, and you just spot it. It's easy to see, right? As soon as the ball hits the bat, you know. That's the sound of the bat, right? The trajectory you follow, you see it right away, but it's important for you to visualize what a home run looks like before you actually start swinging. One way to do so is actually thinking about how to think about levels of prevention. This is what we do in the hospital sector, right? We're tertiary prevention people, we're the rescuers. You see yourself, others in the room in this map, right? Not just levels of intervention, but actually levels of prevention, but levels of intervention. There are people who work on an individual level, person by person, saving lives. There are those who actually organize themselves as organizations. And they think about, hey, maybe we can actually do something for Mrs. M by not just providing her with food, but maybe organizing our hospitals and our healthcare system with our local banks and the debt collectors who are out there and others to reduce the debt burden for high utilized veterans. Maybe we can address that. Or maybe we can actually work even at a broader level of the county or the state, right, for Mrs. M, for people who are already kind of suffering. Maybe there's other people in this room, for instance, who have expertise in secondary prevention at the individual level. The point is, as you map out more and more what exists already in Ventura, right, you realize that we all have relative strengths. The only way to really precisely spot a home run, though, is to get precise about the patient population and precise about a social need that are strategically important. So let's assume diabetics, just for this case study, let's assume food insecurity. And then with diabetes and food insecurity in mind, let's map out all of the different intervention opportunities that already exist. Does that make sense? When you map that out, you start realizing, wait, as a hospital, my boundary ends here. So as a public health department, my boundary ends over here. Maybe there's a gap in the middle, and we can think about together how to create a home run opportunity that bridges our strengths. A simple 3x3, I found, can be really helpful in just kind of setting the stage quickly for identifying a home run opportunity. And by the way, there's a picture of Mrs. M there because, as we've seen from countless examples across the world, actually, there's a hospital system in Sweden. They use a project called Project Esther. Have you heard about this project? They had a quality improvement project. They're trying to reduce infection rates and falls among the elderly who were hospitalized in their hospital system, and they weren't getting enough traction. They had all these departments, nursing and social work and bed control, everybody involved. And then they said, oh, let's create a picture of Esther. Esther is just a persona. And every meeting that they started from then on put the picture of Esther on there. And whenever the meeting would go awry, whenever territorialism or inefficient meeting facilitation or other things would kind of derail you, you just put Mrs. M or Esther right there. And you're like, oh, that's why we're here. That's right. It's a moving needle for Esther, for Mrs. M. So when you identify your home run opportunities, don't get lost in the noise. Put the picture of the patient or the client beneficiary on the stage. Create a persona. Just like people in marketing do when they're thinking about a campaign to sell you the latest iPhone. Right? They have personas of you. They segmented this room way before we did, and they know how to target each one of us. Let's co-opt that. You can use it. We're good. Review upstream data measures. This is where it gets really kind of fun, I think, for those who are data geeks. Get clear on what data matters most. So what's data that's important for Mrs. M and food insecurity and hospitalization? What's a good data point we want to track for an insecure patient? If you're food insecure, what do we want to measure?
You're getting
Food. Exactly, good. So now we can think about food. Like, how does food share or the food bank actually measure doses? These are questions we start asking our upstream partner. Like, what's a dose of food look like? Is it a $10 voucher? So you start to level set on the data that matters most. Focus on the data you have, not the data you want. Don't let like analysis paralysis become the impediment of your work. Pick a screening tool. Anybody know what a good screening tool is for food insecurity? Now you do. This has an 86 to 93% sensitivity and an 84% specificity in clinical environments to identify food insecurity. It's called the Hunger Vital Sign. It's one of about 6 different food insecurity validated screening items in the country right now. If you didn't know how to screen for this, now you do, so there's no excuses. All right? It's called the Hunger Vital Sign. It's been validated before. So here's an example of one tool you can use. 2 items that are administered in different clinical settings can identify how to identify that person for food share. CMS is doing this work. We're working with CMS right now, thinking about how to identify for social needs in general across 32 organizations across the country. So this is happening. A lot of smart people in the country right now at CMS and others are developing the tools. So if you ever ask yourself, I don't know how to screen for this, Google or call, more importantly, talk to each other, you probably have the answer. There's definitely an answer these days for how to screen for social needs in different environments. Because it's being developed. Think about a data strategy. What do you want to collect from Mrs. M? What do you want to collect from the community at the zip code level? And how do you integrate that in your patient workflow? How do you segment risk? Anybody use risk analytic tools? All right, you probably are using a little bit, but if you're looking at risk, our public health department colleagues are definitely doing this. In the healthcare system, anybody using a predictive tool to see if you're going to have a higher likelihood of being hospitalized?
Place tool.
Place tool, but what does that do? Who said that?
I did.
Yeah.
I'm sorry. It predicts your, gives you a score of how likely you are to be readmitted.
Precisely. It's a good tool.
It's valid.
It's a valid tool.
It's used throughout the country.
Great tool. Does it include social risk?
It does look at, I believe, how often you've been hospitalized in the last year.
Great. So it's looking at primarily, and this is not a bad thing, looking at clinical data, right? Including utilization. Now, for all of you in this room, this is actually where you come together, right? Where we actually bring together. That tool that was just mentioned is really looking at clinical risk, high or low, risk of being readmitted, risk of being hospitalized, risk of dying. But it's just clinical data, claims data, utilization data, and that's good. But imagine if you started getting data about food insecurity in a population touched by a hospital or by a social service provider or by the WIC agency, and you started to actually bring that together. Imagine the level of insight you would get into where Mrs. M was at. Because it might be that Mrs. M has high clinical risk and high social risk, but Mrs. X has high clinical risk and low social risk. The interventions look different, right? You allocate your food to people who have high food risk, but you don't spend on people who don't. How can we actually even think about how to address social risk and clinical risk at the same time if we don't map it together to get an even more refined insight of risk? Make sense? This is, look, the NSA and debt collectors and marketing firms do this to you every day. Right now, your phones are getting more insight into risk predictors or predictive kind of ideas, right? Anybody use Amazon? Do they ever tell you something you might like? That's a predictive engine, right? This is not a novel concept, of course, but it's about how do we actually start to get proactive about how to push the envelope, the level of analytics that we want. And social data is one way to get there. Let's get past this right now, even though it's about money. It's probably pretty important. But there's ways to calculate risks and rewards to be able to do this work. And it's for anybody who kind of costs out things, looks at risks and rewards, and says, is this going to be good ROI? The calculators are starting to come out there. So, and then we go upstream. And this is how we go upstream. Anybody ever been involved in a quality improvement project of any sort? Okay, for those who didn't raise your hand, anybody have a relative ever say, can you just do better next time? When you were a kid, anybody say, just swing a little harder next time? Or try, right? Show of hands. Anybody been involved in any quality improvement activity in personal or professional life? Let's do it again. You've all done a quality improvement activity of some sort, right? Formally or informally. Any Lean Six Sigma black belts in the room or green belts in the room? A couple. Anybody want to explain what that means? You're called, the people who have that certification are specialized in a couple of very specific quality improvement techniques that actually were borrowed from the Toyota production system, right? It's what made Toyota one of the leading car companies and other car companies have adopted this to be able to make sure that your car doesn't explode on you. Probably a good thing? Good. Thankfully, our Lean Six Sigma ninjas, our black belts, have actually figured out how to take that same methodology and apply it so that you don't blow up an hospital, right? And that you can reduce infection rates. It turns out we have quality improvement tools, whether you've done it personally or you've done it professionally. You've had experience in using quality improvement, and it turns out this is the only way that I've seen in countless direct experiences and across the country for how extremists actually move the needle with rigor. It's not a rocket science, it's actually improvement science, right? And let's say, like a good QI project, we have a project charter. Anybody ever been on a QI team before? Show of hands on our hospital side. And our community-based organization side, anybody been on a QI team? Here's what I invite you to do. In going upstream, people who raise their hands on the hospital side are now going to invite you, I hope, to be part of the QI committee with them, the social need committee, because that's how you work in teams. So can you have hospital and public health and community-based partners working together on the same QI committee around a particular target issue? If you do so, now we're using machinery of improvement to say we're going to hit a 30-30-30. We're going to improve screening by 30%. How much are we screening now for food insecurity? Good. So how easy is it going to be to hit 30%? Really easy. Guess what? That's in change management. That's called an early win, right? How are you going to feel after you hit 30%? Pretty good. The point is, use quality improvement, borrow and steal ideas from across the country. Look, this is Ohio. ProMedica Toledo Hospital in Ohio took a food pantry, kind of what Food Share is doing and others are doing. They put it into a hospital. They put some rigor behind it to connect it to a referral program. They called it a food pharmacy. If Ohio could do it, we could definitely. Anybody from Ohio? Sorry. So, right? Come on, California, right? So the point is, we can do this in a way that makes sense. Here's anybody recognize this? Healthcare.gov a couple years ago. Anybody remember this? Yeah. All right, 55 contractors were involved in actually creating this feed. Right? They were smart people, talented people, but they were using the wrong approach. They're using an approach that many of us actually use. It's called a waterfall approach, where we kind of plan, design, implement. We put Gantt charts in place that specify over the next 5 years exactly what the world's going to be like. And then we say, it didn't really work out that way, did it? If you're looking at your phone in your pocket right now, wondering when this guy's going to stop talking, it's going to be in 30 seconds. But also, when you look at your phone, you realize that phone is in your hands because your software developers and phone company, Apple, etc., Samsung, they didn't use a waterfall approach. Otherwise, you would never have that phone in your hand. They used Agile principles. Agile is essentially define, build, release, define, build, release. And every time you do that, you get a picture of value instead of waiting for a long time. The waterfall approach is not something I recommend using. Don't go chasing waterfalls from the upstream. Right? Do not, because waterfall works when you actually have certainty. When you know exactly what the evidence-based guidelines are for food, when you're not trying it out, when you're trying to figure out, when you're building new collaborations, don't use waterfall all the time. Flex and try nimble, agile principles. The same things that got your phone in your thing, your phone in your pocket are going to be able to get you quick insight into what's working and what's not working. And then start with our operations folks in the house. Plan out your workflow. Not rocket science. You do this all. Some of our nursing staff, leaders, you do this in your sleep, right? In the hospitals, our public health and community-based organization staff, when you're forced to put together a work plan together for the funder, you do this in your sleep. You know how to do this. But do it for this. Create a workflow that makes sense and map it out. For Mrs. M, we're going to create an upstream QI workflow for food insecurity. We're going to put the Hunger Vital Sign in place. We're going to assign roles and responsibilities, refer to the food share, track how this is going, and measure it. Because if we don't measure it, then we have to improve on it, right? And then I'm going to skip past this part and just say this is the last part. And then you can optimize it. And this is where it gets really fun, I think. And 4 years ago, we worked with 100 high school students, 12th graders in South Central Los Angeles. And we said, look, there's a clinic at UCLA that isn't actually figuring out how to screen. Their hearts are in it. They've heard this great presentation by this compelling physician, and somehow they're not listening. Because, of course, it's not about giving men a fish. It's about teaching men a fish, right? So these high school students use what pharmaceutical sales reps do. Anybody ever been detailed by a pharmaceutical sales rep? I'm a pharmaceutical sales rep. I'm going to meet you at your office, Dr. Hoffman. So nice to see you. How are the kids doing? Great. Remember that drug we talked about last week? How's that going? And all of a sudden, prescribing rate goes up for that drug choice. It's a $30 billion a year industry. 81,000 detailers or sales reps from pharmaceuticals companies go out to doctors every day. These 12th graders learn how to use some of the same techniques, but instead of selling drugs, they learn how to actually talk about how to go upstream. They learned about social needs, bringing their own lived experience to the table. They mapped resources on a Yelp-like database. Maria, Mrs. Kim's class, said, here's the Los Angeles Regional Food Bank. I've called them. I've corrected the information that's online. And then they went to UCLA and they detailed doctors. They learned how to detail, like the pharmaceutical detailers and sales reps do. And they tripled the confidence of the doctors to actually do this. Because first, it's kind of novel to have a 12th grader come to you and say, hey, doc, just for a second, these students from South Central went to Westwood. Anybody know that geography? This is a big deal for those kids. It's a lot of courage it took for them to actually do this, right? But once they found their voice, they didn't lose it. And they walked into the doctor's offices and the doctors heard what they had to say. And that's what led to, I think, the most profound thing, which is the students themselves became teachers. They improved their own knowledge and confidence to address these social needs. You have community organizations, you have people with lived experience. We call them patients. We can call them beneficiaries, clients, constituents. They are people, and many of them actually are people that not only you have served, but can actually become change makers. It might be 12th graders. It might be somebody who's been formerly homeless. It might be somebody who's formerly addicted, working through it. Somebody who has that power can actually come with a technique, with some rigor, and help improve the value of their interventions there. So I think together we can figure out ways to, as we do this work, by the way, kind of demonstrate the ROI here and move money upstream and cost save, right? So we can pull resources and get there. There's a recipe that makes sense, and this is what we've done together. Together in this, remember the care team that formed at her bedside, we helped avert 2 unnecessary admissions. We improved her satisfaction with healthcare. We gave her food and more security and peace of mind, and her blood sugars improved correspondingly, as did her life. You take some of the cost savings that were generated out of that, the averted hospital admission, those costs. You got smart finance guys who penciled it out and said, oh, okay, well, if you got that, 10% of that's going to go upstream into your community diabetes program. And now you're actually starting to think about ways to correct that imbalance in a way that is sustainable over time. If we do this work, I think we can figure out how to finally get to collective blame. I thank you for your time.
I hope that you're getting a lot of food for thought. Here in a minute, we will have a panel discussion and you will be able to ask questions. In your folders, you do have a little paper where you can write your questions. Now, 2 things were mentioned. It's a small piece of paper, but you can definitely use the backside if you need to. If you have lots of questions, we'll provide that. A couple of things I want to. So I'm sure you've picked up that folks like Dr. Manchanda are not your typical providers. They are disruptors. They force you to think differently. Dr. Huffman mentioned that I think you were referring to this mentor of mine, Mitch Katz. He continues to misbehave like he did in San Francisco over in LA. And if it weren't because of his disruptive thinking, I think LA would not have been any better for all the years that he's been there. And it is folks like that that we need in our system to think a little differently, change the status quo thinking, and try and really do the stuff that you're talking about. He did take quite a bit of heat for not putting the MRI in. But at the end of the day, who can speak to when your patients are saying, I got the care I needed, I have a place, I have a job, I'm a productive citizen. How do you fight that then? And saved money. So he's done a few other things like that in LA, and LA is, I think, as a result of that, benefiting from that. Now, I'm going to introduce 2 other individuals that if you look at your program, you're wondering, what are lawyers doing here? We do need them, very much so. And I do want to thank actually somebody that our system is very familiar with, Dr. Stu Siegel. I don't know why he retired, He's
His
way.
wife asked him to.
Oh, his wife has. See, these wives are really problematic. He's a young man. He should be working, especially with our new hospital. So Dr. Stu Siegel was a pediatric oncologist with our system here. And many of you got to work with him and know him well. He now is a board member for our foundation. And it was some conversation he and I had many months ago where he spoke about his wife and what she does. And that's actually what's led to today's event. So I want to introduce you to Barbara Siegel. She was a supervising and managing attorney at Neighborhood Legal Services of Los Angeles County from 1997 to 2011. She was the original supervising attorney involved in establishing and implementing the Health Consumer Center, Neighborhood Legal Services of Los Angeles, which I mentioned earlier, project funded by California Endowment. The Health Consumer Center operates a multilingual health rights hotline and advocacy program for low-income residents of Los Angeles County, offering everything from telephone assistance to representation at administrative and court proceedings. In addition, HCC offers outreach and education on health benefit programs and does health policy work at the local, state, and federal levels. While with the Neighborhood Legal Council, Neighborhood Legal Services, Ms. Siegel supervised the initiation of their medical legal community partnership at Northeast Valley Health Corporation's Sun Valley Health Center, St. John's Wellchild and Family Center, and Clinicas Oscar Romero. Those are the centers she worked with to establish support for them. Now retired, Ms. Siegel currently teaches 2 courses at Gould School of Law and Tech School of Medicine. And these 2 courses have to do with legal and social determinants of health in vulnerable populations and medical legal partnership seminars and practicums. The courses, which are both clinical and academic, teach law and medical students to identify unmet legal needs that impact health and to work collaboratively to improve individual and community health status. So she brings both lawyers and physicians together. They can interact, talk, and help the community. Prior to joining, this is where her interesting part of life comes, because I can relate to it very well. Prior to joining the Neighborhood Legal Services, Barbara worked at the law firm of Bonnie, Bride, Mueller, O'Keefe, and Nicholas. Before attending law school, she worked as a physical therapist, specializing in the care of persons with chronic disabilities. In addition to her degree in physical therapy, she has a master's in public health from UCLA School of Public Health and a law degree from Southwestern University School of Law. So you can imagine she's been a little busy, but she still found the time to come here and talk to us about what she's going to share with us this afternoon. So I want to thank you very much, not only for being here today to talk to us, but for helping me connect with Rishi and with Jerry. Thank you.
Johnson gave me all 5 minutes. And my first opening is going to be, what's a lawyer doing here talking to you? You're trying to address the social determinants in a healthcare setting, and you're saying, a lawyer? Lawyers and doctors don't usually get along so well. But I'm here to tell you that we actually have very similar interests in terms of improving the health and well-being of the community, of your patients, of our clients. In Los Angeles, to address the social determinants of health, we followed a national trend that's called a medical legal partnership. In Los Angeles, we call it a medical legal community partnership because our intent was never to help each person individually. There's not enough of us professionals to go around to do that. We really need to use our community resources and to do a lot of systemic work. So what the lawyers do here, I'm going to give you one example, and you can ask for more if you want them. But hypothetically, we have a 35-year-old man who's homeless. He is on general relief in LA that gives you a whopping $221 a month. I don't know what it does here in Ventura County. Does anybody know? Every county has their own general assistance or general relief program. It's all paid for by county money. So this man appeared in the urgent care or emergency room at LA County USC sometimes 20 times a month, and he often spent the night sitting in the waiting room at the county hospital. Finally, the urgent care doctor came to me and said, "What can you do here? What are we going to do with this man?" And she was tearing her hair out because he came in and he never had an actual physical, need that he needed urgent care in the emergency room. So we sat down with him and we realized he had a quite serious mental health problem. And we determined that if the medical record was sufficiently documented, he could actually qualify for federal assistance of SSI, or Supplemental Security Income, and then he would get $900 a month. And moreover, that would be federal money, not county money. A big win for our county to get us off of using our county money. So we worked with the doctor in urgent care to develop this record. We assisted the client to apply for this program. It often takes a long time to get on, but because we had a well-developed record by the time he applied, he successfully He got on. Moreover, because we have the tax in LA County, we have something called Housing for Health. And Housing for Health meant while he was waiting for his SSI to come through, we used health money to pay for a supportive housing situation for him. When he was in supportive housing, guess what? He took his medicine because there was a community health worker there to help him out, to make sure that he took his medicine and to ask him how he was doing. Guess what else? He stopped coming into the urgent care emergency room because he had a place to be. He had somebody who was watching over him. And his health improved miraculously. And what did we do? All we really did was connect the dots. We got the doctor, we got the attorney, we got the social workers to work together, and we had a triple win. The client, the patient is healthier, following his medication routine. The county is now off the hook for using county dollars, we're using federal dollars. And the emergency room is less crowded because he's not in it. That is where we can work together as a collaborative to try to improve the health status. You don't have a medical legal community partnership in Ventura County yet. So you don't have one yet. I'm hoping that someday you will. But I have asked your local legal aid representative to come here today, and she can explain to you what type of services she can offer to your patients, hopefully her future clients, how to get in contact with her, and maybe as you begin to work together, you can apply for some mutual funding to try to establish a medical legal community partnership here in Ventura County. So I'm now going to introduce you, Monica De La Hoya. She's from the California Rural Legal Assistance Agency, which is the legal aid agency that serves your county. Monica.
Hi everyone. So yes, my name is Monica Lagalia and I'm the directing attorney of the basic unit of our local office. California Rural Legal Assistance. We are a statewide firm. We have offices from El Centro to Marysville. But our office here located in downtown Oxnard serves Ventura County and South Santa Barbara County. Now, when I want to differentiate between basic and migrant, because it's important for you to know that we have a migrant unit, which basically means migrant staff and migrant funding, dedicated solely to provide services to migrant farm workers. And the bulk of their work has to do with labor, making sure that the labor code is followed as far as getting paid minimum wage, overtime, meal periods, rest periods. They also, the migrant staff also does pesticide safety and a lot of sexual harassment and discrimination in the workplace. Our migrant staff we have someone that's, everyone's bilingual, but we also have 2 workers that one speaks in Bajo and one speaks in Bajo. The basic unit, which I manage, we basically serve everyone, and we cover all the areas, which are housing, labor, public benefits, education, and civil rights. Now we're a small office, so we have priorities within each of those areas. And I would say that housing is the #1 reason that people walk in through the door every single day. And because there's only 2 attorneys, myself and a staff attorney, and we have 1 community worker, there's only so much that we can do. So our focus for the past few years has been preserving subsidized housing. So for example, when Dr. Hoffman mentioned his patient, if that patient had gone into his appointment and been denied because of something that showed up in his background, we would have represented him. Once he's in the program, if something happened and they tried to terminate him from the program, we would represent him. If he had a disability or developed a disability and needed some sort of reasonable accommodation that wasn't being granted, we would represent him at that point as well. Now, because we receive so many requests for housing assistance, what we try to do is twice a month, we have workshops that we open to the public where we don't require anyone to do an intake or we don't make any determinations as to eligibility, where we basically provide community education and outreach on basic landlord-tenant rights, security deposits, evictions, habitability, which is a huge problem in Ventura County, and the eviction process, and then we also do labor rights, but the housing workshops are the ones most commonly attended. And if you, for example, wanted your office or your space to be able, if you have space in your office where you think it would be helpful to post that information, we have a list of about 20 groups in the county that we send our updated flyer to every month. They print it out, post it, and that's how that's one way in which people find out about the workshop, and they just come basically to be educated and know about their rights. There's lots of misconceptions in housing. People don't know what their rights are, and they think the rights that they think they do have, they don't have them.
What's the name of your organization?
Yes, California Rural Legal Assistance. I'm going to leave my card and rural, R-U-R-A-L. I'm going to leave my card and some flyers up here. And I mean, as far as referrals go, I know that, for example, we've worked a lot with behavioral health. So, for example, once I meet a behavioral health worker for the first time, after our initial conversation where we know each other and they know about the types of cases we do, I will usually get an email from them saying, giving me the heads up about who's coming in, and then I'll let the front desk know. And that's usually the best way to contact us first. If there is a particular case where you think like this person really is a good candidate for your services, that's the best way. But people generally, we're open 9 to 5, Monday through Friday, except Tuesday mornings we close for administrative meetings. Otherwise, we also do intakes over the phone. Lots of people have a challenge getting into our office, so if they have a phone or email or fax, a lot of times I'll serve people completely without ever meeting them, and just because it's too hard for them to come to our office too. Thank you.
We'll continue to work with our rep. She doesn't mind and establish that last step she's mentioned for Ventura County. We do know that here in Ventura County, Monica, That is a huge problem. There is some effort going on from the county side, but again, as many of us can come together to solve the problem, that would be great. So I know we are running short on time. I'm going to invite our panelists, if Dr. Huffman, Barbara, Monica, you please, and Dr. McKenna, he's getting some water. I've asked Dr. Lava and 1, 2, 3, 4, 5, 6, and Rigo also to sit up front. Elaine is available also to ask questions. So let's have these folks sit. And the questions, and if you haven't written the questions, that's okay. You can raise your hand and ask the question as well. Are there any? Okay.
This is the only one from Monica.
So once again, can we give everybody a big hand for I hope this allows all of us to think a little bit differently than what we have been doing and improve the health of our community. I'm going to have Dr. Lambing, if she would be so kind enough to read those questions for the panelists and they can answer.
Sure. Starting with one of our invited guests, Dr. Manchanda. In your final slide, you note that cost savings due to 2 avoided readmissions could be reinvested. However, that cost savings benefits the payer, like the insurance company. How do you get those saved dollars to public health and other systems that are focused on prevention? Wouldn't this require a change to how health services are reimbursed?
Yes.
Yes. Next question.
There are a lot of good examples that are out there of flexible financing arrangements to be able to. No, there's not. I was talking to it.
Is the mic on? Can we check the mic?
Okay. So there are a lot of examples while I'm working on the mic. Of flexible financing arrangements that have been utilized, everything from social impact investment bonds, social impact bonds in general, health impact investing, frankly, also just cost sharing and gain sharing kind of arrangements in different structures. So it really depends on what the level of organization is. Is it a healthcare, is it a hospital and a clinic? Is it a hospital, clinic, and a food bank? Getting into the specifics is really important because then you're able to analyze the true risks and rewards for each of those partners and identify areas to align those incentives. And there are various different payment models that are out there, many of which I think are pretty common sense that can be applied to be able to think about modest ways to transfer funds or compensate people. So it might just be a case rate, right? It might just be paying the food bank a case rate for that work. It might be a different basic fee-for-service kind of rate, or a more value or outcome-oriented payment model. But the answer usually is it's absolutely possible. It just requires some rigor and bringing the right people together.
All right, Monica De La Hoya.
Can I just comment as well? That,
oh, yes.
You know, there's always a further upstream, whatever you look at. And so ultimately solving these problems involves changing the way we do healthcare in this country. And hopefully we're getting closer to being able to do that, because as our system careens out of control and costs a huge amount of money and with terrible outcomes, there's more and more reason to do that. But even while we're waiting for that to happen, it's always useful to remember that there are powerful interests in all of these things. And I don't think we should fixate on saving money, because we should do things because they produce better health for our population. But it is always nice that you can engender support from groups that might otherwise be adversarial if you can show that you can actually save money. And for most of these things, it is interesting. Somebody mentioned before, somebody's come up with a graph looking at the total spending for social needs and healthcare in all of the advanced economic countries. And the U.S. is right in the middle as a percentage of GDP that we spend on this overall thing. But what's really fascinating is that we spend twice as much as any other country on healthcare and half as much as any other country on social care, things like housing, food, support, etc. So it's always nice to be able to make the case that we're not just asking you to spend lots and lots and lots of money and you just do-gooders out there and who's going to pay for this. The fact is we can easily pay for this. It's a matter of aligning our priorities, and it's important to have that if you want to deal with the potential adversaries who don't want to get in the way.
Some of the discussion today was regarding the upstreamists. We need to look into our own group regarding upstreamists. Who have you found to be some of those powerful upstreamers in your experience?
I'll give you an example of someone. There's a lot of people that you guys, I think, can each name. Let me give you an example of some of the unsung extremists that are out there. There's a resident barber, guy, Adam Chickadee. Adam is a pediatrician. He trained at a public essential hospital in San Francisco. Was convinced by his experience in the residency clinic that he staffed that there's immense problems with poverty. Surprise, surprise. And what he did to his credit was to work with mentors and others who helped him to launch a financial security clinic. He called up a couple of local institutions that provide financial counseling and said, hey, can you come into our waiting room and provide some financial counseling? Because they're waiting. And it's probably better than the Highlights magazine in the pediatric clinic. And their program is just like the one that Adam created as a resident, right? In pediatrics in a public hospital. Upstreamists aren't just the folks who get the kind of top bill in a conference or are for very good reason achieve a certain degree of professional acclaim. The extremists that are out there are the folks who every day are working in systems that think about systematic solutions. And this is a difference that I want to call out. I don't think an upstreamist is just someone who wishes they could do better, who cares a lot about food insecurity and cares a lot about social issues. That's good. It's necessary. It's essential, but it's not sufficient. An upstreamist is a job. You show up, you work, you collaborate, you toil and struggle, you succeed, just like everybody else's job. And until it's somebody's job, it's nobody's job. And that's an important distinction. It's not just about feel good or think good or believe good. It's about action.
But how about turning the question around to you guys? I'm sure there are people you can identify in your community who've thought outside the box and are thinking about how do we deal with this on a level that's beyond just fixing X clinic or Y clinic. Why don't you guys tell us, give us an example of an upstreamist in this community? I am sure Johnson does.
Other than Johnson.
We have one in the back.
Someone said that my company, it's been backed by a Las Islas clinic, and in doing so, there's a radio and digital, broadcast music, and soon-to-be health messages from the health department. They provide food, financial, legal information. They support community workers, and right now ICE is grabbing one who is very much an advocate for women's rights and instruction towards women, towards cancer, towards tobacco cessation, and it's very, very important to support them, and because they're a very important upstream part of our health.
Any other questions from the audience? Some of the questions were related to, for instance, our specific patient population. Several of these questions are related to how do we help the folks that are in our system that are undocumented. And that's and some of the questions also related to, for instance, ICE and what's been in the paper the last 2 days, the gang injunction. So is there anything there that we should pose the question how we might be able to help our community, considering what we've discussed this afternoon?
CRLA, we have restrictions on whom we can serve because we receive legal services corporation funding. However, when we do community education and outreach, we don't do intakes, and we're not giving legal advice, we're giving community education. And we do have a community worker, for example, who's a former social worker, and he has been pretty active in participating in giving Know Your Rights presentations. And it's been two ways, either him seeking out groups or groups seeking out him to go and speak as well. So, you know, he brainstorms ideas and he'll go out and offer the workshops, but a lot of it has been groups reaching out to him. So that's one way, you know, reaching out to like someone for CRLA and saying, you know, it's this group of patients, or, you know, even during our, you know, for example, you mentioned the waiting room, you know, that's one place where information can be given out, or, you know, just have a place where brochures can be handed, you know your rights information.
Johnson.
Now, Monica works at the California Rural Legal Assistance Organization. There are other organizations in every community that can address specific immigrants' rights. In LA, I know we had Know Your Rights for doctors and other health professionals. We have them at the county hospital, we have them at clinic, so that professionals would know where and what to tell people when their patients complain to them, when their patients were perhaps afraid to get health care because they were afraid there might be a raid even at the clinic. I agree with Monica in terms of the waiting rooms, and one of the very good ways to reach the Latino community is through a telenovela in the waiting room. You know, all waiting rooms now have televisions, but you can create a very specific for your county telenovela about these immigration issues, about ICE, about what to do, what papers you should have ready, how to take care of your minor children should you be detained by ICE.
There are, just one other thing, there's an emergency Medicaid, Medi-Cal that you can get without reference to documentation status, but that only lasts for a certain period. So it's transitory. So it's useful in an emergency, but it's not good enough. In LA, they have created a separate program, Healthy LA, which almost everybody who's in it is undocumented because it's to cover the gap between those who don't qualify for Medicaid and after emergency Medicaid has run out. So that's something that you guys should be thinking about, is what in your county can you create that is an ongoing program. Now, of course, that doesn't address the issue of I'm scared to apply for it because somebody will get the information and that might harm me, and that's where we need our friends who have legal skills to help provide safety. But there are things that can be done that you need to be able to work.
Hi, I'm Elaine Crandall from the Behavioral Health Department. So my interest in this area would have to deal with the trauma that's related to families who might have been separated as a result of some of the immigration concerns that are going across in our state and our country. So we have a work group now that's focusing in that area. We have a history of going out into the community and dealing with community trauma. For example, when there was a train wreck and when there are community events where there might be issues of violence in the workplace, we've actually gone out to communities and do that with a whole cadre of community service workers. But beyond that, this particular issue as it relates to immigration and familial trauma is something that we're just beginning to focusing on now. On Friday, I met with an organization, and tomorrow is on the agenda of our executive team committee. It's an organization called Give an Hour. I don't know if you've all heard about it, but this is a national organization that has a chapter here in California where they are focusing on two populations. One is at-risk youth, and the other is families who are experiencing trauma based on our immigration issues. And basically what it is they are soliciting for therapists and psychologists to give 1 hour a week And every patient that applies for it, and it's as simply as going online, you pick your therapist and you get an hour a week of therapy for a year. There's no application, there's no eligibility. It's a really safe place for people to actually receive therapy services. We're very interested in that because we do know for ourselves, there is anecdotal evidence, if you will, of people being afraid to come into our services who are experiencing this trauma. So this will give them yet another segue into receiving mental health services.
Okay. Any other questions you might have? All right. Yes, sir.
Thank you, Dr. Montando, for your inspiring talk on mushrooms. I have a quick question, not to throw negativity onto it, but
bring it on.
What are some of the threats to this upstreamist model that you've seen working with different communities, different systems, health systems? What are some of the threats in a general sense, and how do you kind of prepare and engage those systems to prepare for those threats?
Yeah, lack of will, lack of rigor, and lack of accountability. Right, it's somebody said before financing, it's will, right? That's a matter of everybody in this room saying, what's the thing that Ventura needs to do to be able to create the financing pool to make that happen, or organize around it. Lack of rigor. There's a lot of great, well-intentioned work that always, as we know, starts to fall by the wayside when there's not a rigor applied to this. And it's time for us to get rigorous about expectations of ourselves and our partners to be able to work upstream in a way that's not just about charity care, but about something that is professionally required. And then lack of accountability. How are we doing? Right? Do we have the data to be able to hold ourselves accountable? Is it transparent? Are we sharing this data with our partners, not just in the hospital, the healthcare side, and the public health sector, but with the community-based organizations and vice versa? These are structures that, these have always been the answers for every major change, every major initiative. We've all studied these in our professional degrees. The history of public health, the history of social movement, the history of medical transformation has always been about will, rigor, and accountability.
Is your PowerPoint available on?
Yeah, we'll share this.
Yeah, we will make that available.
Okay.
Mine is too.
It compresses, there's a little bit of a Can I ask a question, Johnson?
Yes.
What are the early wins? What are early win possibilities here? I mean, based on the expertise in this room, what do people think is an early win opportunity? And maybe Johnson, let's hear. I'm just curious what that is.
Obviously, I can speak to that for quite a while, but can one of the team members, somebody want to speak to that? So early wins for us, I think.
Social determinants.
Yeah, early wins for us. Since my arrival, one of the things that we've been focused on is to take the strength of the system, which means we have 2 hospitals, we have a vast network of primary and specialty clinics, behavioral health clinics, public health clinics, to bring them together. So that leadership has engaged into a lot of conversations about integrated care from a patient's perspective. If we can do that, then we can also start to figure out what the gaps are. Not all of those gaps will be filled by us, so we are beginning to engage our partners where they can fill those gaps. And obviously, this is a result of that. But that, I think, is a quick win for us, to use the system that we have so that we can provide that integrated care that the patient needs. And we are, it's interesting that you mentioned, we didn't use the term food pharmacies, but the concept is being discussed with food share. If we could do that in our primary care sites and do that. So that's early win. I'm sure you're aware of the Whole Person Care Project that is in the waiver. I think we have a lot of opportunities there to learn much about this population and to begin to offer
offer some of those solutions to our population. Here, those are some of the immediate things that we can benefit from. If there isn't anything else, I would like to first thank the organizers again. This took a lot of effort on your part with your full-time jobs trying to put this together. I want to thank all of you for volunteering your time this afternoon, several hours, driving time, getting here, now getting back home in traffic. Really want to thank you. And all of you for coming and hopefully getting some thoughts of how we as the healthcare agency and our community partners are going to work together moving forward to make our community better. Thank you very much and have a good afternoon.
Yes,
like, this is where we want to go, and try to give a quick talk on the topic at the time. And like, remember that amazing talk that John did? Right, so that's what we need to get to, so. Yeah.
Oh, yeah.
Right, well, that's the benefit that we have here. Is that
Right?
Nothing, and that is.
That's our, he's the CEO of the Army. Yeah. Who actually used to be the CEO of the healthcare agency. Yeah, so he does come from that background. Yeah. Yeah. So, I imagine something else totally. I think probably tends to be a little bit before from Johnson, unless I still for myself. But we're not good at it.
Right, yeah. What might be helpful is maybe go back to the model where you say, and they say, this could be actually microwave people who are doing that right now. There's people like now, but detailing.
Now
you're paying back, right? So steady, you know, the first step in the room is like, is a big question, right? So that's.
So we have a thought that the playing field thing, especially when you have a lot of stakeholders, many parties.
Right.
That was okay.
Oh my goodness, we finally get to meet you. Thank you so much for taking it to tone out. Yes,
that is describe. That is the piece that needs all of that. You know, the other stuff, getting folks to this protocol, to commit to it and work on it, that we can do. It's getting all of you. Some behind it to work with kids. That is the piece. Right. That's the piece that needs the most, you know?
Thank you so much.